So I'll be on my own, so that's like.
No, like, oh, sorry, next patient ready.
I think hospital medicine.
But it'll be fine.
Just do it, yes.
I only have 30
We should
minutes.
do this, and so
So everybody is more
changing
changing thing.
all with it.
Yeah.
Okay.
Wait, wait, a couple more or just keep going?
I mean,
We can get started.
yeah, you can get started, I'm sorry, yeah.
No worries. Well, thank you. Good morning. Thank you for inviting me to give Faculty Journal Club today. For those who don't know me, I am Terry Montague, one of the transplant nephrologists here. Way to get rid of this thing.
Yeah.
If you go to more. Yeah.
You're gonna.
Yeah.
You're gonna shift control alt H, yeah.
If.
The high floating or shift control alt H? Yeah, yeah. Down, 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 yes. Yeah.
All right. So I chose an article today not to have you guys fall asleep, but this is one that we find that it's very important now. We find this finding on a lot of our kidney transplant biopsies. And the issue is that we all don't really know what to make of it. So predominantly today, we're finding that these findings raises more questions than answers. And you guys will be actually seeing these findings on your kidney transplant biopsies. And I think it's very important for at least for you to know kind of what's going on behind the scenes and where we need more research. Into advance.
You think if you on that side and then it'll,
What's here?
oh, no,
Anywhere.
yeah. Yeah, now you can press her.
Maybe the arrow in the left corner. Like a little arrow.
Okay, I need a tech advisement. All right, so I've got nothing to disclose. And so a little bit more of a background. We see this a lot in all the transplant slides. Retransplantation is the treatment of choice in most patients with end-stage kidney disease. We've had a lot of potent immunosuppressive meds that have reduced acute infection rates, and 1 minute graft survival exceeds about 90-something%. The problem that we still have is that we have no improvement in long-term allograft outcomes. Even though we have improvement in acute, 1 year survival rates, the long-term prognosis is pretty poor. Now, apart from recurrence of kidney disease, antibody-mediated rejection, we find is a major cause of transplant failure, and it's also a major obstacle to improving long-term outcomes. And the term antibody-mediated rejection here, I'm going to include acute antibody-mediated rejection, chronic transplant glomerulopathy, and all of those things are all the one bracket. I'm not going to talk about cellular rejection. And so just to give you a little bit of background, because I know we have a couple of students here in terms of antibody-mediated rejection. So our conventional understanding is that your immune system recognizes donor antigens with the presentation of specific donor epitopes to your adaptive immune system. Your body forms antibodies against these epitopes, which then essentially binds to what we talk about donor HLA on graft endothelial cells, which then activate the classical complement cascade, which then leads to what we call C4D deposition. Basically, it's a breakdown product of complement. It's a marker that there's complement activation and essentially formation of the membrane attack complex. Together, this all leads to direct endothelial and parenchymal injury. Beyond complement activation, it's felt that these donor-specific antibodies that your body forms can also cause injury through antibody-mediated cytotoxicities. And we're not going to go too much in this, but this is also a marker that maybe complement would not be a factor in that. All right, keep reaching for the arrows. So this is just a schematic in that you have donor HLA presenting antigens to the antibody system, activating complement and essentially leading to a cascade that leads to damage. Now, in terms of the diagnosis of antibody-mediated rejection, as the fellows all know, we look for certain things on a transplant biopsy. Essentially, we're looking for findings of microvascular inflammation. By this, we mean inflammation of the glomeruli, as well as inflammation involving the peritubular capillaries. We also look for detection of donor-specific antibodies, meaning we're looking at blood work where we have single antigen beads, where we know what the donor HLA antigens are, and we have beads that you can take a recipient serum and see if they have reactions to the different donor antigens. And then we have staining we talked about the C4D staining in the peritubular capillaries, and we look at that more of an indication of complement activation. So this is an example of glomerulitis. You can see that we have like B cells in the glomeruli as well as the peritubular capillaries, and this is the brown staining is a marker of C4D staining. I'm just going to go over a couple terms because throughout this paper, we used a lot of these terms. We're going to use the G to mark glomerulitis or inflammation of the glomeruli, PTC for peritubular capillary inflammation, and then C4D complement C4D staining. When we talk about chronic changes, we essentially put a C before the word, before the letter. And so when we talk about chronic glomerulopathy, we're talking about transplant glomerulopathy, findings that you've had ongoing injury to the basement membranes. And so you have reduplication of the basement membranes as well as peritubular capillary basement membrane thickening. For all of these, they're graded from 0 to 3, with 0 being no inflammation or no scarring, and 3 being the most severe. You're asking, where am I going with this? We're getting there. And so when we talk about rejection, particularly on the biopsy, the most recent criteria that we use is the Banff criteria, and you're asking us why Banffs. These guys had a good deal going. They essentially found somewhere nice where they can go and discuss the ideal criteria for rejection. And I've gone to Banff, Canada. It's a beautiful place to visit. Essentially, they meet every 2 to 3 years and essentially revise and come up with new criteria. The most recent one is the Banff criteria in 2022. For antibody-mediated rejection, we do need to meet all 3 criteria. It gets a little bit confusing because you can find certain things that appear in both the first and the second criteria, and there's just little nuances between them. But for the most part, you need to have a histological evidence of acute kidney injury, including 1 or more of the following. We talked about before glomerulitis, also peritubular capillarities. And this is, of course, in the absence of recurrent or de novo GNs. You can also find intimal or transmural arteritis. And then we also have the category you can have thrombotic microangiopathy, but you of course have to have it not due to something else, or even ATN. Reason why it gets a little bit confusing is if you look at criteria 2, so if you have findings that there is antibody or evidence that there's antibody interacting with the endothelium, it can include the C4D staining that we talked about. We also find that here we also have at least moderate microvascular inflammation. So we talked about here having glomerulitis or peritubular capillaritis. Here, you're looking for glomerulitis and peritubular capillaritis, but you have to have a score that's greater than or equal to 2. And again, the absence of de novo GN. We also find that they've done studies that they're finding that you have patients that may have donor-specific antibodies, but without particularly signs of microvascular inflammation. They found in studies that there are certain gene transcripts of things that get upregulated. So if you have findings of that, that can also classify as part of the criteria. And then criteria 3, you're finding that there's evidence of circulating antibodies. So you can either have donor-specific antibodies, C4D staining, and again, you can also have these validated transcripts may substitute for that. I'm getting somewhere with all of this. I'm sort of setting the stage for you guys because when you get into the paper, essentially, we're talking about some of those classifications, and I want to make sure that you're kind of following along. So I know it's a little bit dry right now, but we'll get there. And then we have changes, basically chronic active or chronic active, which basically adds on findings of scarring or reduplication of the glomerular basement membrane. So just to kind of take a step back, we now have the BAM criteria of 2022. It wasn't always this way. Essentially, in the beginning, if you had a kidney rejection and they found that you had preformed antibodies, that was antibody-mediated rejection. And as you can see, as you went throughout the years, they kept adding on more and more to the definitions of what constituted antibody-mediated rejection. And what I found interesting, because essentially I did my training in transplant about 2015. I took a break and did general nephrology, and then I came back to a little bit of a difference in terms of criteria. What I found was essentially as you went through these different criteria up to 2017, the number of diagnoses of antibody-mediated rejection increased until about 2017, where essentially they did something there where they actually found that the numbers in terms of antibody-mediated rejection, the numbers decreased. And essentially what happened is that they eliminated categories that didn't quite meet the criteria for, and as I discussed, for antibody-mediated rejection. So they essentially eliminated a category suspicious for antibody-mediated rejection. So you might have samples that had inflammation, but not to the degree that met the criteria. Or you might have samples that had a little bit of inflammation, but then maybe had circulating donor-specific antibodies. And so since it didn't meet criteria, the biopsies were essentially coded as no rejection. The question is, did that limit, or is it true that those samples meant nothing? You should just say, call it a day, no rejection, move on. And so the 2022 reiteration essentially went back and looked at a lot of these samples, found that there are those that did not meet criteria. And the question is there any clinical relevance should we be paying attention to these samples? So this is sort of setting the stage for what they're talking about more in this paper. So allograft microvascular inflammation is the hallmark finding in antibody-mediated rejection. Even now, I have biopsy findings of graft microvascular injury, but we find it without just circulating donor-specific antibodies or positive C4D. So if you remember, I talked to you about the criteria. You have to have microvascular injury, circulating donor-specific antibody, or something that takes the place of that, or also C4D. So you met one of the three criteria, What do I do with that? We also find that we have circulating donor-specific antibodies without meeting the criteria for microvascular injury. Don't really know the clinical significance of it. It raises a question, though, is do we really understand all the mechanisms at play for antibody-mediated rejection? We talked about traditionally, you have antibodies, they bind complement, they cause injury. And there are other mechanisms that is at play, because the issue is, depending on what mechanism it is, you may want to decide or design different treatments for what's happening. And if you have no idea what's going on, how are you really gonna design treatments? And right now, if we were talking about, and you guys have had patients with antibody-mediated rejection, I mean, when you talk about acute rejection, maybe you'll have benefits for the plasma exchange, IVIG, Rituxan. But on the back end, we find that you can biopsy them maybe a couple of months later and you still have the same findings. What do you do then? Do you throw more of that, the medicines that you just gave them again? Or is there something that we're missing? And this is why I said this paper kind of raises more questions than I have answers. But I think it's interesting in that these are areas that we need to have more information.
Terry, that's a good quick question. So when all is said and done, I mean, what is the gold standard? You know, where they say definite AMR, is it because you know that responds to a certain treatment, or just like, you know what I mean? Like, it would be nice to have a gold standard for all this kind of stuff, but
I have to say, I find antibody-mediated rejection to be the most difficult thing to treat.
yeah,
I'll have patients where they'll have a lot of donor-specific antibodies. I'll give them the cocktail. They respond clinically and their kidney function's getting better. The levels of antibody levels may go down. And then a couple of months later, the levels are high.
yeah,
There are patients, we have a little bit of antibodies, we give them the cocktail, nothing seems to have helped.
right,
And we repeat it, the antibodies are not high. And it's a question of what do we do? I mean, if you look at, and I just threw this slide in here just because you're looking at the level of, okay, I will get to it, but you're looking at the level of clinical evidence for some of the treatments that we do. And I think we still have a long way to go.
and to your point, the more mild forms, if the gold standard treatment doesn't work well on what you know is AMR, then yeah, exactly, right.
Right. So I just wanted to call BAM 2019 versus 2022, a little bit of the differences here. So you would have patients that had microvascular, you're looking at the microvascular threshold of glomerulitis and peritubular capillaritis plus or minus 2. For those that actually met the threshold, okay, we then went on to evaluate C4D staining and donor-specific antibodies. If they've got both of them, both criteria said you've got antibody-mediated rejection. If you had either C4D or donor-specific antibody, because some of them can actually count as double, you got antibody-mediated rejection. But here's a category: no C4D staining, no donor-specific antibody. The BAM 2019 said that's not rejection. The BAM 2022 doesn't say that there's rejection, but it highlights that it's there. So I think when you look at biopsy reports, they may not call it rejection, but they're essentially letting you know that it's there, and it's up to you as a clinician to decide what you want to do with that information. You gotta love it. Now, there are patients.
That is not, yeah.
There are patients that have had diagnostic features of, meaning that they have some microvascular injury, but it's below this threshold. Okay. Then when you evaluate for C4D, if C4D positive, both of them calls that AMR, just because there is that one criteria that says as long as the PTC plus G is greater than 1. You've had patients who had C4D negative, but donor-specific antibodies positive. BAM 2019 would essentially say there's no AMR. BAM 2022 would say, maybe there's probable AMR. Again, you get to decide what is this you want to do about it. And they both agree that if there's no C4D or DSA and you don't meet threshold, that there's no AMR. All right, so that's kind of putting it out there. So BAM 2022 created these subcategories for you to kind of look out for. And then going to your point about the treatment, we have, hey, if it occurs early, these are kind of the cocktail that we give. And then because you're essentially trying to get rid of antibodies, the idea behind these adjunctive therapies is to essentially try to keep the body from pain. Late AMR, I think we basically try to do the same thing. When we have chronic AMR, now there's studies that maybe you can give IVIG for 6 months, maybe that will help temporize things, but does it really do anything? When I was initially training for chronic AMR, you're like, that kind of sucks, but your outcome is poor and there really isn't anything else to do about it. I came back into practice, I'm seeing a lot of these protocols and I'm trying to weigh for myself what's beneficial for the individual patient. Alrighty.
Are you using some complement inhibitors?
There are some places that have thrown in like a paluzumab, all these other things because no one really knows. Bortezomib, no one knows. I have a patient, I think it's one of your attendings had someone come back from another country where they've been treated with this cocktail of plasma exchange, IVIG, bortezomib. I think I meet them for the first time in clinic tomorrow, and it's going to be a question of what do I do with this patient? Where do I go from here? So I would love, especially when you're training as a fellow, you like to go, okay, we'll do this, and this is what happens. Here's an area that maybe some of you will decide to take on, and maybe we can get somewhere with this. All right, so that brings me to the actual journal article, and this is a group of doctors essentially out of Paris. This was published in the New England Journal of Medicine in 2020. So this group decided, we've got these 2 most recently recognized subtypes. Is there a clinical relevance to them, or should we just essentially ignore it? And of course, the big answer is probably going to be no, just because I'm talking about this. And so what they decided to do is that they had about, let's call it 6,700, 6,800 adult and pediatric transplant recipients. And they had biopsy samples from these patients between the years of 2004 and 2023. It involved patients that were at European and also North American transplant centers. And some of these patients were also patients that were taken from other cohort groups, meaning they were doing studies for something else and they were able to get those samples. So we had a Paris transplant group, University of Wisconsin-Madison. There's also a pediatric NIH cohort, and there are also patients that were involved in different clinical trials. Of course, for all of the different trials, their patients and legal guardians provided written consent. The study protocol was approved by the IRB of the Paris Institute, and of course, it's all conducted in accordance with good faith measures. Biopsy was performed by either you had an indication for the biopsy, or some of these patients got their biopsies based on different protocols for the different studies. The data collected from the type of transplant, it was recorded in a database at the study center, submitted anonymously for analysis. They looked at clinical biographic data. They looked at all of the, when we talked about all of the PTC, the Gs, interstitial inflammation, all of those things, they're all coded. So they were able to then put this into a database and then have a BAM automated computer system basically spit out the diagnosis based on all of the information that was inputted. So they're able to kind of drill down, and then they were able to design for each biopsy whether or not it met the criteria for the BAM 2019 as well as 2022. So they basically assigned it to BAM 2022 and 2019. So they did look, however, at outcomes based on the BAM diagnostic allocation. And the outcomes that they looked at were primary outcome allograft loss. This is defined as a return to dialysis or preemptive or patient went on to get another kidney transplant. They also looked at secondary outcomes, whether or not these patients developed new or recurrent antibody-mediated rejection or even signs of chronicity, transplant glomerulopathy. So they looked to see what was your first microvascular inflammation diagnosis, whether or not it met the criteria for rejection or whether it was one of those subcategories. And then they looked thereafter to see did this patient more likely to develop antibody-mediated rejection down the line. Okay, okay. Usually when I read this paper, as you look at all of the statistical methods, I'm just gonna say they described it very well in the paper. I'm not gonna go into all of it in detail here. They essentially then conducted risk assessments at the time of the allograft biopsies, and this is what I was talking about. So essentially, the first biopsy that showed microvascular inflammation, they then used that to determine kind of looking at prior outcomes. And then if their rejection episode did not occur, they just looked at the first biopsy after transplant to say this was kind of the category for that patient. They went out for a maximum of 10 years after biopsy, and they did the subgroup analysis, association between the microvascular lesions and essentially outcome of the two subgroups that we talked about. Excluded patients included patients with BK nephropathy or newer recurrent glomerulonephritis and patients who had multiple organs. If you had a liver and a kidney, you were excluded. They limited the time of event analysis to those patients who had more than 1 year of follow-up. Because if you're trying to look at outcomes thereout, it's nice to have people who've had multiple samples more than a year. So just to give you an idea of the recipients, on average, they're about in their 40s. Most were male. Here, the common diagnosis of end-stage kidney disease in these patients, and kind of similar to what we find here, except that we have more glomerulonephritis. They talked a little bit more about the donors. I'm not going to go into too much here, just because they seem, essentially, it is what it is. Interestingly, when you looked at the findings of rejection, so here are patients that met the criteria for antibody-mediated rejection. If you looked at those who were getting biopsies, the majority were those that were being done for a clinical indication, meaning creatinine went up or something else was they found. In terms of probable antibody-mediated rejection, I guess the majority were for clinical indications. And then here's the subcategory: microvascular injury, donor-specific antibody negative, C4D negative. Those biopsies were also being done as well for clinical indication. This is sort of giving you more information in terms of, glomerulitis score, and basically people fell into the category, very little microvascular inflammation or not, as we talked about the different criteria. There are about 2,500 biopsy specimens that had rejection according to BAM 2022. And according to BAM 2022, about 12,000 specimens without a rejection related diagnosis. Median time from transplant to biopsy was about 8.1 months. In most of the biopsy specimens. In terms of the patients that had the microvascular inflammation, that was about 788 specimens. Median time for biopsy is about 11.3 months. And again, there's that range. Probably antibody mediated rejection was about 10.7 months. Just giving an idea, the patients who fell into these phenotypes, the two that we talked about, there are about 788 specimens, of which 3.1% fell into the microvascular injury, donor-specific antibody negative, and C14 negative. The probable antibody-mediated rejection was a lot lower in terms of numbers. I found this to be the most interesting part of the paper, because when we looked at patients that were classified in 2019 to the 2022, we had about 641 patients who were classified as no rejection to now something to look out for. We had in the MVI, DSA negative, C4D negative, 391 of those patients. Probable antibody mediated, 250. This was really interesting. We had patients that were kind of falling into the T-cell mediated rejection category that was also now being placed in these different subcategories. And I looked to see, well, why is that? I mean, if you're T-cell mediated, you're T-cell mediated. Well, these patients also had some arterial inflammation and mild to moderate microvascular inflammation. And then in some of the patients that were borderline suspicious, we also got a couple more patients that fell into the different categories. And so this is the 2019 patients in this class, non-rejection, that were able to then fall into either of these two subclasses. So this is what they found. So they took those patients who had been reclassified and essentially looked at their outcomes in comparison to those who had had rejection and those who did not have antibody rejection. And essentially, this is kind of looking at probability of graft survival over 10 years, where for those patients who didn't have rejection, this is their slope. The patients who fell into the probable AMR class, meaning they had some donor-specific antibodies, but they didn't meet the criteria for microvascular injury, don't think this is quite that significant, but I think essentially when you look at the numbers, the question you have with looking at the trend is if you had more patients in these populations, maybe you didn't see much of a difference. But what was interesting is this subcategory, microvascular injury, donor-specific antibody C4D negative, even though the numbers itself were low, you found that their risk for graft loss increased by a hazard ratio of about 2.1. Here. And it's kind of following the same trends as also those patients who had antibody, who met the criteria for antibody rejection. So it kind of begs the question of these patients that fit into these categories. Can you really just say no rejection, ignore them? What do you do with this category? That's the question. I don't have an answer for you, but I think this is just a paper that guys will end up seeing these diagnoses on biopsy, and you'll end up calling us, asking us, what do we do? And I'm hoping that in a couple of years, we might have the answer for you. So they also looked at the risk of new or recurrent antibody-mediated rejection during follow-up among these patients. They also looked at the cumulative incidence of transplant glomerulopathy. So this paper was very difficult because they threw different numbers and different denominators at you, especially if you went through it. But they had about 5,000 patients that they included in the analysis. And what they found is that when they looked at new or recurrent antibody-mediated rejection. So here's the line. If you've had a finding of antibody-mediated rejection, your likely incidence of having more would follow this course. If you had no rejection, your likely course would be here. We found that those two subcategories kind of followed an intermediate trajectory, meaning you've got microvascular injury, no donor-specific antibodies, C4d negative. It was somewhere between active antibody-mediated rejection and no rejection. Probable AMR, somewhere in between two. So it means that there's something going on. What it is, we still have to elucidate. But we also looked at development of chronicity, of scarring. What's really interesting here, there's kind of a flip, but I don't think in terms of numbers we have enough. We have active AMR, no rejection. They also followed an intermediate trajectory. So the bottom line is these carry subcategories. There is some impact on clinical outcome. And it's felt that this, using the BAM 2022, will more effectively reflects the prognosis if you're going to stratify patients based on biopsy for these patients. The problem, again, is what do you do? And I think you first have to identify the problem before you can then go back and determine what to do. And so I keep saying this over and over again, and I'm not going to bore you with the details. The authors essentially said, I think, or they think, there's probably other mechanisms at play rather than just the standard that we know. This study does not tell you what those mechanisms are. They threw out things like, well, maybe this is a pathophysiologic process linked to the innate immune response rather than a humoral response with B cells. And that allo recognition is driven by NK cells. Of course, I went looking at papers regarding that, but this study does not exactly tell you that this is what's going on. But they're essentially mentioning that we need to study this further. Right now, I think there's also studies looking at CD38, markers and things like that. The problem is, some reason, recruiting for antibody-mediated rejection studies, quite difficult. When you look at these studies, you'll see they'll start off with 20-something patients. It's very difficult to recruit. The study closes. So this may take a while for us to actually get through. And the reason I'm trying to let you guys know is that you'll have patients where you'll have these findings. Hopefully you'll sort of look your local transplant center, say, hey, I got this finding. Can this patient potentially be involved in one of the studies? Because we do need more information. We're losing too many of our grafts to ongoing inflammation. Strengths of the study, we had a lot of samples. Weaknesses of the study, we really couldn't tell what the different immunosuppressive protocols were. You could go back and look, but there was not really a standardization. They were taking patients from we're doing different studies. we really don't know. For those people who met the BAM 2022 for these subcategories, what people did with it. I'm sure you've had patients where you have microvascular injury. And based on, maybe their creatinine's rising, even though they don't meet criteria. You might say, let me throw something at it, just. Us. We don't really know if any of those patients got treated. I mean, it stands to reason that their outcomes were poor regardless of what they got treated with. And they didn't really take for each individual patient sort of protocol biopsies for you to actually follow what the natural evolution was. We're kind of looking at different samples and trying to figure out, well, this is kind of what happened. We need more studies of that. It kind of sucks, I'm sorry. And so my take home point is that this essential study suggested that subcategories have worse outcomes in terms of prognosis. We don't really know the insight on the mechanism. We don't really have standard treatment regimens at this time. And I think looking at other pathways is going to be the way to go. It's one of those. But I think it's an important topic because when you guys get biopsies, a lot of times when you don't understand things, you'll pick up the phone and call. And yet it's good to understand where we also stand in terms of when we say, you could do this or you could do that, but we don't really have a lot of data right now behind. Questions?
Yeah, thank you for that review. That was really helpful, recognizing the sort of enormous gray area. But I think engaging it is important and laying this out is helpful for me. I read these biopsy reports and don't know what to do. I think it's helpful to know that you don't know either. No, really, because here's what it comes down to. When you're in the clinic with the patient and the two of you have to come to an idea of what are we going to do here. I think to be able to start from a place where you can confidently say no one has any idea, then you can say, well, how aggressive does this person want to be? Because what we know in the clinic is what are the clinical circumstances? Is this a 25-year-old kidney in a patient who's got a lot of other things going on? Or is this a 3-year-old kidney in an otherwise healthy young person? I mean, how aggressive you're going to be and how much you're going to try, whether it's going to work or not, who knows? But I might not, in a 25-year-old kidney, I might not give them eculizumab because it was a good run. Let's just get another kidney. But at 3 years, right? Like we got a long way to go here. Let's be more aggressive. So I think understanding what the possibilities are from our standpoint in terms of treatments, understanding with the patient that this might not do anything and it might expose you to toxicity, but we don't know, and just being able to explain that uncertainty is valuable, I think. I mean, that's what I take away from this.
It's exactly the point. I mean, I have patients, or I had a young lady who meets every single criteria for rejection. You're starting at 3 months after transplant. Maybe she had low levels of DSAs at the time of transplant. She still has low levels of DSA. You do a biopsy and it essentially shows she has microvascular inflammation. And she also has the fact that she has some DSA, the criteria, she has C4D staining. And so you give a course of plasma exchange, IVIG, Rituxan. 3 months after that, biopsy looks exactly the same. For that patient, you ask yourself, is there any benefit for giving more of the same? Now you get to someone that doesn't even meet the criteria. These are the things that I'm struggling with, and I know my colleagues are struggling with as well. And then you're trying to look for studies that maybe, I think Dr. Cooper, James, has a study where he's looking at CD38 inhibitors. But this patient may have 1V1 lesion that keeps him out of the study. So there you are.
Okay, so for that patient, for example, she meets the criteria slightly and got the treatment, but the other patients that don't meet criteria, but if we see that even those people do worse, that have worse outcomes, wouldn't it be reasonable to treat them even if they don't meet the criteria, knowing that they will do bad?
These are the questions. If you treat them, and then what do you treat them with? And then also the ones that don't have any donor specific antibodies, the non-vascular injury, C4 negative, DSA negative. Everything that we have, the plasma exchange, that's designed to get rid of antibodies. IVIG, designed to get rid of antibodies. Rituxan, you're going after a B cell. Is it gonna be beneficial for this class of patients to expose them to that toxicity? Without knowing, is it gonna be a benefit? And again, that tip goes to the point of having that discussion with the patient, but from a mechanistic standpoint, it doesn't feel that great, you know, like, there's no antibody, what am I doing?
I think that in like a lot of these patients were getting the biopsies because of the clinical indication. So they're giving like, and then here
You
we
want
don't
to do
do
something.
Yeah, we don't do protocol biopsies here. So like here, we're getting the biopsy because of creatinine's rising. So that's, and then if they just have MBI, nothing else.
There's some steroids at it.
Yeah, right.
I mean, I might decide to do that,
Yeah.
but, you know, think about trying to tell an insurance company, I wanna try some of these new treatments. Someone that doesn't quite meet criteria and there's not really a study.
And you just have an observational
And
study,
you're-
right? Like, I mean, that's the other problem, it's observational, you don't know where there are other things. The biopsy could have been 10 years before they're even looking at, they didn't get rebiopsied. Right, cause I
And
mean,
we spend a lot of
that's-
time with the insurance company going,
they were protocol.
I mean, when
They
you
could have
combine
been-
protocol biopsies
Yeah.
and clinical indication biopsies, right there, you're in trouble.
It's totally different.
Because a protocol biopsy at 3 months or 1 year or 2 years, and then you find this stuff, but nothing's going on. Treating those people probably isn't gonna help, there's nothing going on. It was interesting to me that patients with antibody with like honest to goodness, antibody mediated rejection, that curve flattened out at about 30%. It's hard for me to believe that everybody with antibody mediated rejection at 10 years, only 30% of those people.
But
lost
the
their
number,
kidneys.
the number goes way down.
Way down.
The number
Thank you.
at risk, it's like,
numbers for.
Right.
there's very few people got
So those-
biopsies that way.
Those curves are deceiving.
Yeah.
Right,
Where they separate early is probably the more valuable piece of that, but it's just, I mean, and it's hard to do these studies as you.
It's very hard, yeah.
Terry, you mentioned this, to me, that's one of the main limitations is how heterogeneous this population is. All the centers
right.
across the Atlantic, doing really what they thought was the right thing with.
Well, yeah, you don't know how old was blood pressure, other
Yeah.
things that could have led to that.
Right.
Like blood pressure, diabetes back, like, other things that could have happened in that 10-year span or follow-up. And that's the hard, but
This is what we
that's what
got.
you found. That's
So you could be doing, they have those transcriptomic panels where they look at all the change. I mean, what if you combined, I don't know if anybody's doing this, you combine that plus microvascular inflammation to Michelle's point to try to tease out make this heterogeneous group a little more, better for targeted therapies, for instance. I don't know if anyone's doing that or not.
It's something to look into, yeah.
I don't know, you have to, at the time of biopsy though, you have to preserve them differently for the cancer?
No, they have this panel from Calgary, the one that you get in the urine. Or the blood.
Oh, the urine
Yeah.
one, no, I thought you were looking at kidneys too.
Transcripts, so.
No, I don't know if they're gonna get enough RNA-seq, but they have a whole gene expression.
That you could give them the urine.
It's I think it's FDA approved, right, or something like that, or is it?
I have to double check,
Oh.
but I know there's all the,
Right,
upregulation
yeah.
of this thing or CX3, I mean.
it
There are all
correlates
these
within the
things
tissue.
that I don't use in clinical
It
practice.
does correlate, yeah.
Okay.
But it's not, you can't do single cell definition, so. Yeah.
Maybe we should do that in my transplant study, because we'll have single cell definition and we can
Oh,
get their
yeah.
urine. No, they don't have project, I mean, some of them have had.
Well, that might have
Some of
microvascular
them they have.
information, yeah.
They have had.
Yeah, we should do that.
Vascular.
But
We
that's
could
the thing, and
look
sorry
at.
about the ride that I took you on, but I felt that I needed to kind of lay out there the definitions and things like that, just so you can really.
Oh, yeah.
That was,
They all keep changing.
yeah, it was
Yeah,
good.
Very helpful for us.
That was a great thing,
Yeah.
thank you.
Thank you.
Thank you.
I think these people can fail. They're distracted by the beauty.
And they should be going to the.
Oh, they're not going to the- Oh, there, yeah. Yeah, they go to Banff, but they go to Lake Louise. I feel like they're going to Lake Louise, you know, that's just like.
Actually not bad.
It's like, you know.
Trying to stop the recording. Oh, yeah.
Like, look past these out.
Just spoils it, so getting carrots and.
That's what
Melodies.
That's where we share.
Did anybody?
So I drove to Highlands, right?
Are you going okay? Was it inconvenient?
I hope we can all.
You guys say all that. I got like end of day.
I'm not rushing.
Yeah.
Like, it's all of us, there's no.
There's that, so we got very bad.
You can go on.
Today. Which is a little review, because I haven't done transcripts since like August. So I'm like, I don't think I've done it in a year.
I did 1 week. I did 1 week with six stuff this year. Why? What do you mean?
Like, isn't there supposed to be, you're supposed to do a certain amount? In order
Yeah.
to.
Yeah, but I think they, like,
Do
they,
most
for
of it
first
in
year
first
heavy,
year.
they just make first year heavy for everything.
We made a lot during first year, and then I think I had a week transplant in a way. Because of the situation with having a child. I think I got switched to Denver Health for an extra week. Didn't do, because I'm on a 3-week Denver Health trip right now. Which Denver Health is just busy. It's crazy.
We should develop, so like 1 or 2 weeks.
I only have 2 weeks of July this school year.
I was in the I think I added it up, and I did a lot of Denver Health. Because I think I've done, I think I'll do 8 weeks.
Oh, because I got 3 consults on this weekend.
I didn't.
Half of the TSRD.
That's so close.
So like.
That would have been nice.
8 or 9.
I did kind of like make that clear that I'm like, it would be nice if I could be a Denver Health lot.
Yeah, because you're also so right.
Yeah. I mean, you're even closer.
The guy's been there forever.
Oh, hopefully.
Yeah.
No, but,
Oh, do you know why?
they're like, we want to.
Yeah, that nobody wants to take him, and
Oh,
then
he
he's
set
something
it
about
up.
insurance. He was,
No, but one of the things.
Oh, yeah. But he
Oh,
was
I know mom.
saying that he had money and he didn't want to spend.
The VA for 2 weeks in June, but I've done 3 weeks of VA.
Yeah.
Yeah, thank you. But then he was like,
I know, it's.
Yeah, I got like pneumonia or something, but.
Sigma last
He's
for
back on
the
He had the chance, he was not over it, like it was
disrespectful.
disrespectful.
Yeah.
But then they're trying to spend his money down to buy a car.
he was like a special truck.
Yeah.
It's the same situation. Yeah, the same.
I mean, honestly, I don't know why he himself is still.
It's
22.
great.
Like, why not just?
I thought this was
No,
summer.
Why?
I know, see,
Don't go
I think we know that, but I was just back at like 6 a.m.
He drops me 2 calls.
Oh, usually. Which is the one week.
Like just alternate every week.
That's what.
I am getting like till 50 clear, sure, like, like, it's not a vacation. And I'm
I
like,
feel like most places
I'm like,
Manganese.
or do you want any people in residency to tell me you go back to their school? That's not a joke.
We're like,
That's
okay,
happening.
5 to 7, and then also have to.
So we'll get started on magnesium here. Yeah, right. Really?
How many magnesium stores?
We need to talk about it because it's like always a.
Yeah.
It's almost like magnetic.
Wow. Okay, so we're gonna just go over magnesium today. I actually started seeing more concepts for this in clinic. And I'm not sure like why it's not really, but people get referred a lot in CKD clinic for hypomag, so it's helpful to kind of review and also, we'll also talk about hypermag. But also to kind of like review the different therapy options for these patients because you'll encounter them in clinic, I'm sure. But obviously we'll go over sort of the physiology of magnesium because I think, compared to the other like more sexy electrolytes like potassium, magnesium often kind of gets forgotten about. So, okay, so similar to potassium, magnesium is an intracellular ion. So potassium is the first most abundant ion in the ICM, magnesium is the second most. It's important for regulating your mitochondrial function, immune defense, neuromuscular tone, cardiac excitability. We predominantly are going to get magnesium through our dietary intake, and we typically take in about 300 milligrams per day of magnesium, and about a third of this is absorbed in our GI system. But the vast majority of magnesium is stored in our bone, muscle, and other tissues. Only about 1% of it exists in our extracellular space. And of this extracellular magnesium, about 70 to 80% of it is free, and the other 20 to 30% can be bound to proteins like albumin. So absorption is primarily through the GI and renal system, and then also excretion is through those systems as well. And this is our own Judy Blaine. One of her most cited papers. So in the GI system, magnesium is absorbed primarily in the small intestine. And within the small intestine, absorption primarily is going to occur paracellularly. And that's through tight junctions that are made of claudins. In the distal GI system, it's predominantly through transcellular absorption through the TRPM6 and 7 channels. And that's going to be ileum to rectum. So it's important to note that these channels exist throughout the entire intestine, but in the small intestine, the main way magnesium is reabsorbed is paracellular. And then once you get to the ileum and beyond, it's predominantly transcellular. And then if you increase magnesium intake orally, that will lead to more magnesium reabsorption, primarily paracellularly. So this is a little picture of that TRPM6 and 7 channel, and then your paracellular transport that occurs. In the renal system, magnesium is predominantly excreted renally. And so 70 to 80% of your total magnesium is ultrafiltrable, but then the majority is going to be reabsorbed by the tubules. So your total daily output of magnesium is about 3 to 5% in your urine. And that's important that you can't really ever reduce your urine or your renal excretion of magnesium to absolute zero. Like even if you're hypomag, there will always be some amount of magnesium that's lost in your urine. And your degree of excretion of magnesium is directly affected by serum magnesium. So for example, if you're hypermagnesiemic in your blood, that's going to inhibit tubular reabsorption. Whereas if you're hypomag, that's going to increase tubular reabsorption. And that's important because that helps us kind of have a framework for how to interpret lab results when somebody is, being repleted with IV magnesium. Like what would you expect the renal response to be when you get IV magnesium, that sort of thing. And our ability to excrete magnesium obviously is significantly reduced in patients who have CKD or a change in their GFR. So just kind of working through the nephron. So in the proximal tubule, that's going to absorb about 10 to 20% of your filtered mag. The loop of Henle is going to absorb the majority, so 60 to 70%. And that's kind of different than our other ions, like sodium, potassium. The majority of that is absorbed in the proximal convoluted tubule. The loop is where the majority of your mag is going to get reabsorbed. And then the distal tubule will absorb 5 to 10% of the filtered mag, and then 3 to 5% is excreted. Okay, so just going through each segment. So in the proximal convoluted tubule, this is magnesium's predominantly going to be reabsorbed paracellularly, possibly through clotted tube. In the thick ascending limb, this is primarily going to be paracellular as well. And so this is where our friend ROMK comes back into play. So, you're going to get sodium, potassium, and chloride reabsorption through the NKCC, and then potassium is going to get recycled via ROMK. And the whole purpose of that is to generate a positive lumen potential, which is going to shuttle and sort of push magnesium and calcium paracellularly. So that involves claudin 16 and 19, and that forms these kind of cation selective tight junctions. And then in our distal convoluted tubule, this is where we start to see our little friends, the TRPM6 and 7 reappear. So these exist both intestinally, but also renally. And so this is where you get transcellular absorption of magnesium. So this is active transport using sodium and potassium ATPase. And then it's important to note that these channels are promoted by EGFR. Not estimated glomerular filtration function, it's epithelial growth factor.
Capital.
Yeah, right, exactly.
Take you for a second. No, I know.
I mean, it probably is both, to be fair. So this is just I like pictures a lot, more than words. So this is your ascending limb. So this is claudin 16 and 19, and they come together to kind of help shuttle calcium and magnesium across. And you can see where you're getting this like ROMK potassium recycling that leads to the positive gradient. Claudin 14 actually inhibits, so that's why there's like this little block here. It blocks magnesium and calcium reabsorption. So interestingly, this whole setup is controlled also by the calcium sensing receptor. So, which makes sense, right? Like if you're reabsorbing a ton of calcium, calcium will bind here. It will say, okay, let's turn off this shuttling effect. So then it inhibits ROMK and activates claudin 14 and prevents more calcium and magnesium reabsorption. That's just sort of like our normal homeostasis mechanism. And then in the distal convoluted tubule, you have your NCC, which we know about. And then this is your TRPM6 and 7, which allows for magnesium to be shuttled across. And then this is EGFR. So, oops. Anyways, so factors that increase magnesium reabsorption. So dietary magnesium restriction, obviously, if you have lower serum concentrations of magnesium, that's going to promote more reabsorption. That kind of makes sense. Parathyroid hormone is kind of interesting. This one is a little bit indirect. We know that parathyroid hormone increases the production of 1,25 dihydroxyvitamin D, and that actually increases both calcium and magnesium reabsorption in the gut. So that's how that works. Glucagon increases your magnesium reabsorption both in the thick ascending limb and the distal convoluted tubule, whereas calcitonin, ADP or ADH increases magnesium predominantly in the thick ascending limb. And that's through, they've kind of looked at that through like a lot of mouse studies essentially. Calcitonin is going to inhibit your calcium sensing receptor. So then you're going to get more ROMK activity and more movement of magnesium across that claudin. And then insulin acts more in the distal convoluted tubule on the TRPM6. So insulin stimulates that transcellular channel. Okay, so just going into hypomag, that's sort of our physiology. So with hypomagnesemia, obviously the definition of this is low serum levels of magnesium. It's typically less than 1.5, but I think every lab is a little bit different than the cutoff is. It can be asymptomatic, which is the majority of the time, but you can get signs and symptoms of it. So you can get muscle aches, cramps. I think that's what people mostly complain about, is feeling that muscle cramping, fatigue, generalized weakness. The more severe it gets, you can start to get cardiac findings, so prolonged QRS and torsades. And obviously hypomagnesemia can affect other electrolytes as well. So these are the effect on the other electrolytes. So obviously if you're hypomag, that's going to upregulate ROMK to try to get that passive reabsorption of magnesium, but that in effect leads to more potassium secretion. So people who are hypomag can develop a persistent hypokalemia, and I think all of us as first year fellows were taught, like, you have to replete the magnesium first before your body's going to be able to hold on to potassium, and this is why. With calcium, so magnesium has an interesting relationship with parathyroid hormone, in that if you have a slightly low magnesium, it actually increases parathyroid hormone because magnesium and calcium are so tightly coupled with that paracellular reabsorption. If one or two of them are both low, that's going to increase parathyroid hormone and increase mag and calcium reabsorption. On the other hand, there's like this paradoxical block that can occur. So really severe hypomag will actually reduce PTH release, and that can cause hypocalcemia. And then phosphorus, so low magnesium contributes to intracellular depletion. Okay. So why do we get hypomag? So, as Stu would say, we kind of think about it not in lists, but like how it's actually happening. So you can get it because of poor PO intake, or a shifting effect, or increased losses. And that can be either GI or renal. So what are like examples of poor PO intake? These are people who are like severely nutritionally depleted. So you see a lot in alcoholism, poor access to food, disordered eating, or prolonged TPN in the hospital that maybe doesn't have enough magnesium. I think these days we're probably a little bit more careful about that, but historically that's kind of what an example. Redistribution, obviously magnesium, like potassium, can shift in and out of cells and in and out of bone as well. So like hyperthyroidism will shift potassium across, same with refeeding syndrome with the increase in insulin. Pancreatitis actually causes like a saponification of magnesium, and that's how you get hypomag from that. And then hungry bone syndrome. So, we always, when we think about hungry bone, we really think more about calcium, but because like 99% of magnesium is stored in bone, when you get hungry bone, it, affects up all that calcium and magnesium at the same time. Okay. So in the case of, losses of magnesium causing hypomagnesemia, how do we determine if it's like GI versus renal? So you're going to look for your urinary magnesium losses. So you can either do this through a random sample or through a 24-hour urine collection. So your BMAG is your fractional excretion of magnesium. This is your urine mag times your plasma creatinine. And it's divided by your plasma magnesium times 0.7, because remember, only 70% of magnesium is free and unbound. And then you multiply that by your urine creatinine. So if your fractional excretion of magnesium is greater than 3 to 4%, or your 24-hour is like 10 to 30 milligrams per day, that suggests renal wasting. if your Pmag is less than 2% or your 24 hours less than 10 milligrams per day, that suggests a non-renal wasting. So this is the point where you kind of keep in mind that you can never totally turn off your renal excretion. And so you'll always have some magnesium in the urine. People, expect that their magnesium should be 0 in their urine, but you're always gonna have a little bit. And also keep in mind that like our renal excretion of magnesium is really sensitive to what our serum levels of magnesium are, which is why, repleting with one, you really need to measure this prior to repletion of magnesium. So you need to know what their urine magnesium is before you bolus them 2 grams of IV mag. Because as soon as you give them that IV mag and it hits their serum, all of a sudden their kidneys are not going to start, like you're going to see more urinary magnesium. So you want to try to measure this as best you can before they get their repletion. Otherwise, it's pretty hard to interpret the results. Does that make sense? Okay, perfect. You guys know the smart. Okay. So renal causes, or like why we might lose magnesium renally, can be acquired. So a lot of times it's tubular problems, right? Like we're not reabsorbing it paracellularly or transcellularly. So chronic alcohol use actually causes pretty severe tubular dysfunction. And I've actually seen this a number of times, like more than one handful of times where people who have alcohol use disorders or went on like a binge for a few months, develop really severe hypomag. And it's interesting because they might be done drinking, like maybe they're recovered or they're not drinking anymore, but that tubular dysfunction can actually last longer, like for a little while, like months longer than you would expect. But eventually that their ability to reabsorb comes back online. And it's a kind of unclear like why the alcohol use causes that tubular dysfunction, but yeah. So obviously other forms of tubular dysfunction like a post ATN state, post obstruction, things like that. In polyuric or high flow states where you're just moving things through the tubules very quickly and don't have time to have that paracellular reabsorption, so post transplant, post ATN, or like if you're getting a lot of MS or big sodium infusion, that can cause problems with reabsorbing mag. And then metabolic acidosis can cause this too. Obviously medications like diuretics are going to be probably our most common reason we see hypomag. Cisplatin is going to cause tubular damage. Amphotericin, obviously it also causes tubular damage. The aminoglycosides actually, it's interesting, they activate the calcium sensing receptor. And so that inhibits ROMK, that inhibits the positive tubular gradient and leads to the loss of paracellular reabsorption. Cetuximab and panitumumab are EGFR inhibitors, right? So they will block EGFR and prevent that TRPM6 and 7 reabsorption of magnesium in the distal convoluted tubule. Pentamidine causes tubular damage. CNIs, like so tacrolimus, we see a lot of hypomag post-transplant, and it even like years after transplant, and it's predominantly due to the TAC. So tacrolimus really inhibits your TRPM6 expression. And then sirolimus downregulates the NKCC in the thick ascending limb, so you get a loss of that potassium recycling. So I made little pictures here. Well, I didn't make pictures, but I added words. So I'm just kind of showing you guys where all of these like exist. So obviously cisplatin is tubular, loop, sirolimus are going to affect the NKCC. Amphotericin, pokes holes in these tubular cells. The aminoglycosides affect the calcium, activate the calcium sensing receptor. Thiazides here. Your CNI is going to downregulate your TRPM6. And sirolimus blocks this, and then cetuximab can tune that from the EGFR. So other causes of hypomag and things you will see a lot as well are diabetes. So diabetics just have a higher likelihood of having like mild hypomagnesemia than most people. And I think the thought is that like the TRPM6 and 7 are stimulated by insulin. And so patients who are, especially who have type 2 diabetes, just have like a more resistance to insulin. And so those channels just don't work quite as well as they do in people who are non-diabetics. That's sort of the theory, but it's not like 100% that's what's happening. But you will see people like, if you get referred somebody for hypomag, maybe they're on a PPI, but maybe they're also a diabetic or they've got something else going on. And then in hypercalcemic states, obviously that's going to bind that calcium sensing receptor and block that paracellular reabsorption. Okay, so there are genetic causes of hypomag. We know about Bartter syndrome and Gilman's. So remember, Barter's is in the thick ascending limb. I think Dr. Montfort always tells the medical students that the Bart is loopy, like Bart Simpson's loopy. Well, how you remember it. Yeah, so that's an autosomal recessive disorder that's predominantly characterized by salt wasting because you've got mutations that are going to affect the reabsorption of sodium and potassium chloride in the thick ascending limb. There's 5 different mutations that are kind of written about there. But you also get a hypomag because you lose that recycling, and you obviously get metabolic alkalosis primarily because of a secondary sort of hyperaldosteronism because of all the salt wasting and kind of chronic hypovolemia that they get. Then the FHHNC is much more rare, but this is a familial hypomagnesemia and hypercalciuria with nephrocalcinosis. So it's a claudin 16 mutation. So you're not able to reabsorb calcium paracellularly or magnesium. So you get low magnesium, and then you get a lot of hypercalciuria, which promotes kidney stones. You can also get claudin 19 mutations, similarly to claudin 16, but I guess they have high issues as well. And then you can get a calcium sensing receptor mutation, like a gain of function, essentially. In the distal convoluted tubule, that's where Gittleman's is going to occur. So you get the similar picture to Barter's, where you get hypokalemia, metabolic alk, hypomag, and hypotension. They, the difference between Barter's and Gittleman's, Barter's is characterized by hypercalciuria and kidney stones because of that, because of how calcium and magnesium are reabsorbed in the thick ascending limb. Gittleman's doesn't get that because it's kind of past that point. But essentially in Gittleman's, you get a mutation of this SLC12A3 gene. So that causes a loss of the NCC and leads kind of indirectly to a downregulation of the TRPM6 and 7, which is why people with Gittleman's get hypomag. And then more rare hypomag with secondary hypocalcemia or HSH. So autosomal recessive loss function in TRPM6 and 7. So you're getting renal and GI wasting, because remember TRPM6 and 7 exist in the GI tract as well. And then a mutation in EGFR can lead to isolated renal hypomag. These are very rare. I don't think I have one patient with Barter's, and like I've never seen the rest of these. Maybe Shrey has probably seen one. So just more pictures about where these exist, and I for some reason put in animations. But so Barter's is red. It's gonna be there, but you also get you can get mutations at all of these spots where the red X's are that can, there's 5 different mutations and they affect these different spots depending on which mutation you have. And then your claudin 16 mutation, your claudin 19 mutation, and then your kind of upregulation of calcium sensing receptor mutations there. And then in Gittleman's, obviously you get problems with NCC, but also a downregulation of TRPM6. And then with HSH, you get a TRPM6 mutation, and then you can also get the isolated EGFR mutations. Okay. So that's sort of the renal excretion that can cause, why we have renal wasting of hypomag. And I would say renal causes are very common, but so are GI causes, right? So, a big reason why we get hypomag can be from diarrhea or a decreased ability to absorb magnesium in the small intestine or in the distal intestine. So it can be from just, diarrhea, whatever, but also malabsorption syndromes, so Crohn's, steatorrhea. If you have a decreased surface area to absorb magnesium, so like gastric bypass surgery or the Whipple procedure. And then the big one that we see a lot and that we think of a lot are PPIs. And the way those work is because they inhibit that TRPM6 and 7. So unfortunately, that's why they cause low mag. And then obviously medications that increase diarrhea, laxative abuse, or magnesium supplements. LOL, because we're trying to give magnesium, but unfortunately, too much can cause diarrhea. And then we're stuck in this horrible cycle. And then genetic causes, so I kind of mentioned HSH in the last one, but that's a mutation of TRPM6, but it affects both the kidney and the intestine.
So do PPIs affect both the kidney and the intestine as well?
I think, yeah, probably to some degree, but I think because they're more enterically absorbed and it's seen more as an intestinal issue. But there's probably some small systemic effect renally as well. Definitely. Okay, so how do we treat hypomag? So, if you can go through the patient's history and sort of identify risk factors, like maybe they're a transplant patient and they're on PAC, or maybe they are on a PPI, or they have alcohol issues, or they're diabetic. Obviously, if you can manage those things, that's great. More frequently, I find that you're not able to. More often than not, the patient can't actually come off their PPI, or obviously they can't come off TAC. So do what you can, and then typically they're on magnesium supplements by the time they get to you, which is great, but make sure that they're, you might see how their GI system has been since starting the magnesium supplements, because if they were doing fine, and then they had an increased dose and now they're having crazy diarrhea, that might be, not great. And then supplemental medications to consider to help improve magnesium would be an SGLT2 inhibitor, and then miloride, tranturine, eplerenone, kind of less so. We'll kind of go into this. So focusing a little bit on mag supplementation, when do you do IV versus oral? Ideally we will do oral, because as we kind of talked about, the faster you increase the concentration of magnesium in the serum, the more renal excretion you're going to start to get from magnesium. So you want to kind of slowly build back the stores. So IV magnesium is really reserved for patients with really severe hypomag, less than 1 milligram, cardiac arrhythmias, severe symptoms. Obviously, you're going to do IV magnesium. If it's over 1, they're asymptomatic, they're able to tolerate PO, then we would prefer PO supplementation. And then this is this is a photo I took from Schreier's book, but this kind of goes through the different weights. You can see the bend in the page. That's embarrassing. But these are, so mag chloride is your slow mag. So the percent magnesium by weight is 11.96. Mag oxide has a lot more, 60% magnesium by weight. This is a better picture that I also took at Kidney Week at ASN a couple years ago. And I thought this was really helpful because this gives you the percent magnesium, so kind of what we saw on that last page, the mag oxide is like 60%. Mag chloride is like 12% mag sulfate. So, but then it gives you the idea of what's more bioavailable, which I thought was really helpful. And then which one causes more diarrhea. So, mag oxide, even though it's really potent, it also causes like the most amount of diarrhea. So that's not super helpful. Slow mag causes less, but there's less magnesium in it. So oftentimes patients have to take more magnesium. Mag citrate obviously is used as a laxative. So it will cause diarrhea. But if you can get it, mag lactate seems to have really good bioavailability and less diarrhea. So you might get a little bit more bang for your buck with that one, even though the elemental percent magnesium is lower.
Is it like, if magnet lactate is like over the counter or the prescription?
Most of these are, patients will go to like Vitamin Cottage or somewhere with a lot of supplements, and there's like a ton of different formulations. So I have like one patient that takes this like weird, she's like on 3 mag oxide, 5 mag glycinate, and like she's on a crazy regimen. And I can't really, she won't let me adjust it, but they like have the ability, the vast majority of this is over the counter. So at supplements stores, you can find these. Okay.
Whoa. There's one on Amazon for 60 tablets for $40.
That's expensive.
That is expensive.
Yeah.
Yeah.
Wow.
What about one wins? Yeah, because these are like the brands that are like very expensive for people.
So, the burden of like all these magnesium supplements plus the GI side effects brings you to kind of your next step, which would be maybe to consider the use of SGLT2 inhibitors. So as kind of a, weird side effect of SGLT2s, there was a kind of a meta-analysis that looked at patients who were diabetic and showed that SGLT2 inhibitors both increased your mean serum magnesium levels and reduced your fractional excretion of magnesium. And there are case reports that show benefit both in diabetic and non-diabetic patients, as well as in patients without overt renal losses. So in people who you think are losing it from diarrhea or from like GI causes primarily, you can still use SGLT2s and they show some benefit. So, and anecdotally, they're extremely helpful. You may not be able to take somebody entirely off magnesium, but you might cut them from like 4 pills a day to 1 pill a day. And they're like magic. If you can get somebody on an SGLT2 inhibitor for this, they work very, very well, which is nice. So this is the little visual abstract for that. But basically, and this looked at mag and phosphorus. And they compared the different types of SGLT2 inhibitors. This is the meta-analysis, and really it's a class effect. So there really wasn't any difference between SGLT2 inhibitors, but it increased it by 7 versus 0.03 for phosphorus. And then, so it was helpful. And that's the kind of mechanism of action, or like why they think it helps is they're not entirely sure, but a couple of theories. One would be that, it reduces your sodium and glucose reabsorption proximally. So you get more, higher positive luminal charge in the thick ascending limb. And so maybe more increased paracellular mag reabsorption. The other theory is that, it's a diabetic medication. So potentially it increases your insulin sensitivity of the TRPM6 and 7. And then also like SGLT2 inhibitors do to some degree increase both ADH and glucagon secretion. So maybe you're getting more distal magnesium reabsorption with that. So what about like amiloride or Theranos? I think classically we were kind of taught to use those medications to help with mag reabsorption. They're not as great. So there were some animal studies that showed that amiloride reduced magnesium urinary excretion. In studies, there have been a few human studies. So in one study, in patients who were on thiazide, amiloride did increase the plasma magnesium, but in another crossover study of patients with Gitelman's, basically amiloride led to a reduction in urine magnesium excretion, but no real increase in the plasma magnesium levels. And so I think the takeaway, like if you look at like up to date, amiloride up to date on hypomag says, you know, essentially amiloride did just this, that it's most definitively it reduces your fractional excretion of magnesium, but like not definitively increases your plasma magnesium levels. So, you know, if you're really desperate, maybe you can try it, but I would try the SGLT2 inhibitors first. And anecdotally, the SGLT2 inhibitors work a bit better than amiloride, so.
And you've had luck getting it like approved for like
Yeah,
ICD-10, hypomag.
yeah, I mean, I don't know, I think I can't really remember, like, you know, I might do some finagling, you know, if their GFR is like 58 occasionally, you might put CKD, or if they're a diabetic, you might say diabetes, or I don't know that I've been able to, I don't know that I've just done hypomag, but I think I maybe have, and it's been okay. Like it's generally, those medications are that's not word, more easily approved these days, but I think I usually try to find some other diagnosis as well to assist me. So just as in summary, so with this, obviously you try to stop or identify any offending medication, alcohol use, PPIs, evaluate for persistent renal or GI losses, add magnesium supplements as tolerated, but like maybe titrate to diarrhea, and then when they develop diarrhea. If they're still low, consider, or they can't tolerate the supplements, try adding an SGLT2 inhibitor, and then, you know, review other electrolytes that need help as well. So if they're hypercalcemic, maybe try to fix that too. Okay. So hypomag is the majority of this talk, but we'll talk a little bit about hypermag. I don't think we see it as much, but in the patients that we do see it in, it's typically in your CKD patients. And that can be through increased intake, typically through like things like laxatives or antacids, or, you know, like I have some CKD guy who's just like, oh, I'm cramping. So they're just taking a bunch of magnesium. Other clinical scenarios you might see it in would be like preeclampsia, hypothermia. So in patients who have CKD, you know, the way they develop hypermag, it can become very severe, even in patients without CKD in the setting of excessive intake. And that might be that, you know, one, you're taking in a bunch of magnesium that leads to increased GI absorption, but then because it's cathartic, and you develop diarrhea, and causes you to lose both stool as well as sodium and water. You can develop hypovolemia and a pre-renal AKI, which can reduce acutely kidney function and your magnesium excretion. So sometimes patients can develop severe hypermagnesemia without like prior CKD. And it's typically because of that loss of GFR, not eGFR, actual GFR. So clinical symptoms of acute hypermag, so you can get depressed deep tendon reflexes when it's greater than 4, flaccid quadriplegia or a loss of deep tendon reflexes when it's greater than 8 to 10. You can get lethargy, dilated pupils, respiratory depression, smooth muscle paralysis greater than 10, and then hypotension, bradycardia, which leads to complete heart block and cardiac arrest. And this, I think, in patients who, you know, thinking back to med school days, you know, if you have somebody who's got preeclampsia with severe features or eclampsia and they're on a mag drip, the OB residents are always like checking their deep tendon reflexes for this because they run them pretty high. And then treatment of acute hypermag is IV calcium to help stabilize the cardiac membrane, saline, diuretic if their kidney function is decent, dialysis if their kidney function is bad. And actually, I think that's it. Cool. Question? Your new favorite electrolytes.
So And the only reason I asked is somehow is for one of my clinic patients, do you ever like do like the stool studies to kind of work up extra renal mag wasting? Cause like, yeah.
Like looking for like flash in the stool.
Yeah, and like the excretion, electrolyte excretion causes, I like, yeah, I have a patient who's like, mag is 1.2, potassium is consistently 2.4. No matter how much I replete, and there's nothing in their urine. GI has done nothing. They've been successful. And so I'm like, all right, I'm gonna do stool studies myself.
I have not, I've never been in
You
that
know, would sign
scenario.
up. Thank you for this.
But they were having, did they have like some malabsorption syndrome or?
I don't know, they like scoped them and didn't see anything, but then they like never like got like stool studies, and I'm like, oh, my basically I did stool study, like see, and even excretion of any electrolytes in stool, because you can do that for
Yeah.
potassium. I'm like, you said in phosphorus, probably
Yeah.
for mag as well, no. It's not very helpful, then.
Yeah.
Cool.
I mean, I don't know, like, I think clinically, if there was no renal excrete, like, you know, your urinary mag is super low, your urine potassium is really low, and they're like telling you that they're having a lot of diarrhea, I'd probably just assume it's GI rather than eating the stool electrolytes, but I mean, it certainly could, you know, add to your case of that, but.
Yeah, cause I have this lady on slow mag, and then I now have her up to 100 TID of potassium chloride. Yeah.
Golly.
Yeah, I know, and yeah.
And those ones, like, that might be like a hard case where you're like, you know, you might be a little nervous to add an SGLT2, because if they're like having that much diarrhea and they're that
Yeah.
volume depleted,
Yeah.
you'd have to watch. I mean, it could help theoretically, but you'd have to watch their kidney function kind of like a hawk, you know, because they could probably get a bad AKI from that.
Yeah,
And then maybe their magnesium would be okay.
yeah, and then I'm worried about the potassium, because I was like, couldn't do an amiloride.
Yeah,
Because the potassium.
well. Yeah, I mean, theoretically, like the SGLT2, I would be also nervous about amiloride too, because that's also a bit of a diuretic, so. You might try an SGLT2 first, because if you can get the mag up, then you might be able to get the potassium up.
I'm gonna do that.
But, you know, caution. Like I would, you know, I forget what Stu's old like saying was, like, makes you feel a little nervous. Don't feel good about it.
My favorite saying of his is like, this patient doesn't
Work. All right, now I need it.
We updated your slides.
Yeah, thank you. Did I misspell dialysis?
No, it said
It was a
2006.
Thank you. Whew. And then I did just do it last night, but I changed the April 27th, and maybe yeah. I have not been giving this talk since 2006, as you can see. I mean, I wasn't even a fellow. I was just started my fellow. No, I was not a fellow yet. Okay, we started this talk maybe 6 years ago because we thought that we were a little poor in the hemodialysis curriculum of this, of your fellow's curriculum. And a lot of the stuff you get with CKD, like anemia, etc. But this is one of those topics that like I obviously around on a lot of in-center hemo patients. And this is one of those questions that I struggle with the most on day-to-day rounds, exactly what to do about blood pressure, what's the ideal blood pressure, how do you manage it? And I just thought that it would be a good opportunity for all of us to review the evidence. It's a lot like when you all were interns, and you probably remember this, you get called by a nurse that somebody's blood pressure is 175 over 95, right? And the expectation on the other end of the phone was that you should do something about it, even though we know now that there's nothing you need to do about it acutely. They're just letting you know. That's a lot of like rounding into dialysis unit, right? You go by all the machines, some of them have red numbers everywhere, and there's alarms going off, and you're trying to figure out what's acutely dangerous, what is gonna, affect their long-term prognosis. And so I just wanted to go through the data. It is kind of like what Terry showed earlier this morning. It is not high quality, large randomized controlled trials, so we're gonna have to work through the data limitations a little. But I put this case up here. This is an amalgamation of a lot of my patients, but this is a pretty standard thing that you'll see when you're rounding every month or multiple times a month. Challenge. Yeah, so we have a 55-year-old patient in your dialysis unit, been on dialysis for 5 years, just chilling, waiting for the transplant, taking good care of herself, and gets 3.5-hour treatments 3 times weekly, never misses, never shortens. A little unusual, but that's how she rolls. And 2 months ago, when you're looking at her post-dialysis blood pressures, you realize they were a little high, and it got your attention, but you didn't do anything about it. So she was leaving about 150 over 85. And then 1 month ago, you're seeing a worrisome trend that it's 160 over 90. And this month, most of the post-dialysis blood pressures are even higher than that. So 166 over 96. And she sees the numbers too, and you're rounding and looking at the numbers, and she's worried that her blood pressure is getting too high. She wants to get a transplant. She doesn't want to have a cardiac event. She wants to live a long, fruitful life. So she wants to know if there's anything that we should be changing to change her medicine. The one thing that you'll need to know to work through this case is that you have her dry weight set at I can't remember what it was, but she hits it every single time. She does not get hypotensive during her treatments. She does not cramp. And I should say this, but she has no pitting edema or any overt signs of volume overload when you're rounding on her. So initial thoughts. Are we happy with the blood pressure? Not happy with the blood pressure?
Happy.
Not happy. Okay. What would you be happy with?
There's a 130.
130. Okay. At the pre-dialysis, post-dialysis, 24-hour urine, doesn't matter.
Post that.
Post. Okay. All right, and you're probably saying that because pre-dialysis, everybody's fluid overloaded, so maybe that's not the best blood pressure that we should be using. Okay. All right, and we'll start with that because we have a lot of issues to go through. So I'm going to cover 3 major topics today. The first is what actually should be that blood pressure? What are you aiming for? What should you be doing for your patients when you're seeing them on in-center hemo? The second section is probably the biggest part of this talk, and it's about using non-pharmacologic strategies to control the blood pressure. And then third, since most of our patients are on antihypertensives, which classes should we be using? Which specific drugs and which specific classes might work the best for your patients? And we'll go over some of the RCTs that go over that. Okay. So what is the optimal blood pressure for patients on dialysis? So when I was a fellow, it was thought that blood pressure, as opposed to the general population, was a little more U-shaped. And so the general population, as you all know, it's pretty much a linear line, and it starts way below a systolic of 120. But the cardiovascular risk and the stroke risk just go up linearly as your blood pressure goes up. And we didn't know that pharmacologic agents prevented that until the late 60s with the famous VA trial. But now, of course, we have, probably close to 100,000 patients worth of RCTs that have shown different goals, some to Paco's goal of about 130, and that does provide benefit. So the dialysis data, like I said, let me see. Shoot, get my pointer going here. What about the spotlight? Do I get a pointer? Is this the pointer?
What's the?
Sorry, it's spotlight.
This one?
No. Oh.
Now you have to go to the
Spotlight.
spotlight. You think will work?
Yeah, yeah.
All right. Boom.
Yes.
But it's the red dot there.
Okay. Well, that's okay. So this is the data from large. If you look at large observational studies, and this is kind of a famous one from 20 years ago, where it made nephrologists really question how aggressive we should be on blood pressure, because you can see it looks literally nothing like the graph does from the general population, right? There's not a linear increase in cardiovascular risk. It actually goes the opposite direction. And I think we can all kind of figure out, and this is pre-dialysis systolic, this is post-dialysis. So this looks a little better, but definitely not a linear response. And there's a huge confounding thing in dialysis patients. And what would that be? What's generally going on with dialysis patients who run lower blood pressures? Yeah, they're very sick.
Yeah.
They're malnourished. They have cirrhosis. They have heart failure. So you can probably try to control for everything you know how to control for, but the data still gets a little wonky when you try to do all comers on dialysis. But so 20 years ago, the strategy was generally make sure they don't have edema. If they have pulmonary edema, obviously keep challenging their dry weight. But people would let their blood pressures run quite high because there was really no high quality data that it helped. It's a little in dialysis, there's something called therapeutic nihilism where they have such high mortality rates and high morbidity that a lot of people think that it doesn't matter, why do a statin? All the RCTs have been negative. So, and that was kind of what was going on maybe 20 years ago, to be totally honest with you. So then we got a little better data. And this kind of goes to the question about which blood pressure is the best. And so if you look at, this is a nicely done study. I think it's from a large prospective cohort on dialysis. And you have the blood pressure in a dialysis unit, and then you have the home blood pressure. And the home blood pressure looks a lot better, right? So this looks like a lot more like we're used to seeing in the general population. The higher it goes, the more likely they are to have a cardiovascular event. And the dialysis units, blood pressure still do not do great. So that's certainly a limitation. And then this is, I guess it's a little before that study. This is a smaller study, but they were able to try to break out quartiles and different kinds of readings. So they have pre-dialysis routine, and then they look at they do it in quartiles, right? So the first column is the lowest quartile and the last column is the highest quartile. So you can see pre-dialysis blood pressure doesn't appear to predict anything. There's not a linear dose curve. Post-dialysis doesn't do that much better. Maybe the second half. Pre-dialysis standardized, and this is using like the AHA guidelines about when you're sitting down, the oscillometric cuff, yada, yada, yada. That doesn't look great. But so really the two that look the best, as you might predict, would be the home and the ambulatory. And so I think most nephrologists, if you had your choice, you would want your patients to have a cuff at home, go home, check their blood pressure many times a day or many times a week and bring the logs in. I would say that happens in our clinic about 15 to 20% of the time when we're concerned. We bought a lot of cups for the clinic, like the clinic, the clinics don't have them to loan out, so like the providers just buy them, we lend them out to patients. They sometimes make it back, they sometimes make it back with readings, so it's a good thing to try, and I generally, if I am trying to alter antihypertensives or something, I do really want to get out of dialysis unit blood pressure readings for this reason, because the worry, of course, is if you're targeting a post-dialysis blood pressure of 150 too aggressively, and they're having hypotension at home and they have cardiovascular disease, or maybe they have residual kidney function, maybe they'll, you're putting the patients at risk for some adverse events. Okay, so have they ever done an RCT on a blood pressure dialysis patient? The answer is yes, and this was published about 8 years ago now, where they basically took 126 patients and they randomized them to intensive or standard blood pressure. And this was based on dialysis blood pressure measurements. So this would kind of be Paco's goal, the aggressive group, and this would be just, as long as they're leaving around 155 to 165, they're okay. It probably wasn't powered to honestly look at the cardiovascular endpoints, right? It's 60 in each group. But they did successfully finish the trial. And it was tolerated pretty well to go aggressive, which is the good. There wasn't like an increase, I don't think, in syncope or anything. It was a negative trial. There was probably higher risk of access thrombosis with the aggressive group, which is really kind of the only difference that they noticed in this trial. So this is it when it comes to blood pressure goals in in-center dialysis patients. This is the separation they got, and you can see they did do a pretty good separation. They also got home blood pressures too. So they got the dialysis blood pressures, and you could see they went from basically 160 to this group was about 140, which is probably what we would target. At home, they ran a little lower when it started, but their home blood pressures were 135, 140, which I think we would agree is pretty good. So this hasn't really changed since 2023, but this is basically all the guidelines which talk about a blood pressure goal. So they mention this is for non-dialysis patients. And so JNC8 for CKD patients who are not on dialysis recommends 140/90. Obviously, we know like PKD and that couple, like if they have a lot of proteinuria, we generally targeted them a little more aggressively. They want ACEs and ARBs. AHA, ACC targets a little lower. Between these two trials, you do have, I remember when Sprint came out, but now with Sprint, we generally do not do 140/90. We would do a little on the tighter side. The Europeans, and then Hypertension Canada goes pretty aggressive at 120. And KDIGO, if you look at the KDIGO guidelines, which are almost exclusively focused on non-dialysis CKD, they also recommend 120, and that is because of the findings of the Sprint trial. But what about for patients on dialysis? So when I was a fellow, this was KDOQI. Like I said, there was some therapeutic nihilism. These are pretty aggressive. I would say it was very uncommon to get this kind of achieved blood pressure. So then they changed the recommendations and they said, just try to make sure they're not too volume overloaded. But we don't give you a target blood pressure because there's no high quality data. KDIGO, they almost entirely focused on non-dialysis CKD because of the paucity of data. And then the Europeans, they look at the data a little differently. They thought there wasn't enough to recommend a goal. So if you have a 24-hour blood pressure monitor, you should be going for 130/80. A home blood pressure 135/80 on each PD. And as you all know from PD clinic, it is much easier to manage blood pressure in a PD patient because you have at least 31 days worth of blood pressure data for a month. And office blood pressure 140/90 on midweek non-dialysis day. So that's they're obviously not, class 1 recommendations. So that's the data for what you want the blood pressure to be. So what are some non-pharmacologic strategies to control blood pressure? What are the big ones?
Low salt.
Low salt, okay, dietary salt. I think, in Denver, probably our patients eat between 8 to 10 grams of sodium a day, so. Yeah, if they could probably cut that in half, it almost certainly would help.
More you,
That's
Exercise, okay,
way more,
more you.
Yeah.
that's way more than I would have thought.
if you buy that burrito outside Denver Health, you get like 3 grams right there.
Potassium.
But, okay, dietary potassium, okay,
Well, more you.
where are you at, okay.
Yeah.
Challenge their dry weight, something like that, yeah, great. So we actually have data behind everything. Potassium is an interesting one. In the general population, we now have RCTs that increase dietary potassium, lowers blood pressure. And dialysis patients, about 25% of our patients show up with hyperkalemia, so there's probably going to be some reluctance to, it depends on the patient. Okay. So I'll talk about all of them. We'll mainly talk about the fluid removal, but I totally agree with Paco that if you can make it work, I do think the dietary salt restriction will have a large effect. We'll talk about, there is an RCT actually looking at exercise, but most of it will talk about fluid removal. And there's some non-RCTs, like from the Ticine dialysis unit in France. And then there are some RCTs that we can talk about too. Okay, dietary salt restriction. The best paper I found on that is a meta-analysis of 12 studies, 4 of which were RCTs. We're not talking very large studies, right? But 91 total patients in the RCTs, 3 with HD, 1 with PD. And they try to decrease the dietary sodium by at least 1 gram. So you don't even need, if you're, you don't even need to give up all the burritos, just maybe one of them. And then just that small change in dietary sodium in these 3 trials was associated with an 8/4 millimeter decrease in blood pressure. So that's the real deal. I think it's worthwhile to try to work on. I don't know, have you all had success in clinic and in your VA dialysis clinic at limiting patients' dietary salt?
I think it's really difficult to measure it, right? Like,
Well, yeah. Well, how do you do it in the general
Yeah.
population? You do a 24-hour urine, right? Because you assume they're in balance. So you do a 24-hour urine. You can't do that on dialysis, right? So it is hard to know. So they can do it a diary, like a food diary, and they can bring it into the dietitian, and sometimes they can identify. I mean, I think the biggest misconception on dietary salt is that it's the shaker.
Right.
When it's really going either eating out at restaurants or eating a lot of, canned foods and such like that. So
It's a classic. They're like, I don't add any salt to my food.
well, yeah,
I'm like,
ramen every day.
I know when I went to the pizzeria yesterday, I didn't add any more salt to the pizza.
like if you don't have to add salt, that's because it already tastes good.
Exactly. So I do think it's worthwhile, and I do think especially if you're seeing patients with high intradialytic weight gains, it is something that you should try to focus on. Sometimes there might be low hanging fruit, like some patients love soup, and then maybe they could decrease their soup and broth. Sometimes it's not so obvious how you're going to get the dietary salt down, especially a lot of dialysis units have a lot of patients who have a major challenge in food insecurity. And so it's easier said than done to change their dietary habits.
I feel like that's really interesting to me though, that you only need to decrease it by 1 gram. You don't have to get them.
You don't have to go to a 2
0
gram sodium.
Yeah.
Exactly. That's exactly right.
That seems like a more reasonable ask.
Yeah.
So can you do like, oh, I'm gonna increase my salt intake and then decrease 1 gram? That's gonna be an event.
Yeah, I think it's good to get the right baseline. And if the baseline, it's hard when you guys are running in a dialysis unit, you're running on 24 patients, right? So like it's pretty hard to get a detailed example of what they're taking in. But what I try to do is I try to identify a couple people a month who, for whatever reason, have high intradialytic weight gain or struggle with fluid related issues, and encourage the dietitian to work with them. It's just, a lot of times you're resource limited in these situations, but it is a good idea to try to work on it, no doubt. Okay, so here's the largest RCT looking at exercise. And dialysis patients sit there for 3 or 4 hours, they don't really move. So maybe it would be good to increase their physical activity. So the largest RCT was this one, which came out in Jason almost 10 years ago now, 292 patients. They basically got a personalized, a trainer to help them do a home-based exercise regimen or not. You guys might have seen there's some other studies that are much smaller where they bring in the stationary bike wheels to the dialysis unit. It's actually an appealing logic, right? You're actually doing something, staying active. Maybe that increases the blood flow to your muscle and you might, reduce, pull out more uremic toxins. Those have been very small studies, but they have been kind of promising too. It does make sense. But this one is a home-based therapy. Their primary endpoint was looking at functional endpoints, and they do get better. Their 6-minute walk time gets better, their time to stand gets better, and so their frailty scores are getting better. They got a quality of life questionnaire in a hospital, and so like a lot of their symptom burden got better, hospitalizations were reduced. So a lot of good things happen when you do exercise. They did not in this trial see a change in blood pressure. So clearly a supervised exercise regimen would be good for someone's health, but you cannot maybe assume that it'll definitely lower their blood pressure. There might be subgroups in there that you'll see a benefit. Okay. So what about changing the dialysate sodium? What do you guys normally order? 137? You guys tailor it to the patient? What do you all normally do?
Taylor it, but 137 will be.
137, unless they,
My center, unless they're like,
yeah,
one,
okay.
if they're 130, I'll drop like 135.
So when they did dialysis in the 60s and the 70s, it was very inefficient. The treatments took much longer than they do now. And they actually, they wanted to remove a lot of salt. So they put that sodium at 130, but they're running them for a long period of time. It was pretty well tolerated. When the treatment shortened and the dialysis got much more efficient, if you did it at 130, it would be associated with really high amount of hemodynamic compromise because you are pulling a lot of sodium out really quickly at that point. So then they gradually raised it to 140. So like when I was a fellow, maybe before I was a fellow, maybe in the 90s, they were doing 140. And then the worry with 140, of course, is that most dialysis patients don't have a sodium of 140. They're in the 130s somewhere. So if you dialyze them against a 140, you're actually loading them with sodium throughout the treatment. So everything you do about dietary salt is going to go out the window now because you're basically just giving them a ton of salt during the treatment. So then, the last 20 years, they've kind of dropped it because there's probably pretty good evidence that increasing the dialysate sodium may give you increased thirst and dialytic weight gains. Most clinics, if you look at the orders, they actually have a button that says 137 and then others. So I would say the majority of people in our clinic start out at 137, but yeah, you can definitely adjust it based on their serum sodium, based on their intradialytic weight gain, yada, yada, yada. Okay, so this has been studied pretty heavily in the dialysis literature. The studies are very small, but you can see these are all the randomized controlled trials. Most of them are crossover studies where they would do somebody at a low dialysate sodium and then they'd come back and they do a higher one. And you can see they are pretty small studies. But if you add them all together, you get 170 patients. And so a lower dialysate sodium, which would be less than 138, versus a higher one, which would be greater than 140, there is less intradialytic weight gain, which is this graph on the left. And then on the right, it's their pre-dialysis blood pressure, which correlates pretty well with, not quite statistically significant, but I think the intradialytic weight gain is obviously of import to us. The more fluid you gain, the harder it is to remove it in a dialysis treatment, and they're running the risk of volume overload. So it's very uncommon to see people on high dialysate sodiums anymore. Okay, what about doing more dialysis? Does that help blood pressure? And the answer is, in general, yes. So there are two trials that everybody quotes, and I think I've talked to a lot of you about these and had them in some of my studies before. But these were designed to test the hypothesis that if somebody gets more dialysis, their mortality is going to improve and a lot of cardiovascular endpoints are going to improve. The biggest one was called the frequent hemodialysis network trial. They had a daily trial and then had a nocturnal trial. The daily one was basically 3 times a week dialysis versus 6 times a week dialysis. So that's a lot of dialysis. 225 patients looking at death or change in the LVH. And then, and so this was a positive study. So if you do 6 times a week dialysis, the patients do better. It was almost completely driven, and I'll show you this, by changes in left ventricular mass. So more dialysis, more fluid removal probably does help reduce cardiovascular risk, which seems, I guess, kind of obvious when you think about it. But the nocturnal study, they got a little more dialysis in the nocturnal group because they got nocturnal HD. So not just a 3 or 4 hour treatment, they got, 5 or 6 hour treatment at night versus 3 times conventional. Much harder to recruit for this study because nocturnal dialysis is a pretty specialized thing. You have to really choose your patients carefully. So much smaller study. So it was a negative study. They did not enroll any more patients than this. It was definitely underpowered. I'll show you what the secondary endpoints that we get there. Just to give you an example of what they tested in the FHN daily trial, it was basically the frequent got less dialysis per treatment. So, what is that? A little under 3 hours. But they got more dialysis time per week by over 2 hours. And they also got more ultrafiltration per week by about 1.5 liters. And that was associated with much improved left ventricular mass index. It was also associated with an improvement in blood pressure and fewer dialysis, fewer antihypertensives were needed in the intensive group. So, that's proof of principle. The more fluid you remove in a week, the better their blood pressure is and the less likely they are to have LVH. The data from FHN nocturnal, remember this is a secondary endpoint, so it's still a negative trial, but this part, the secondary endpoint, which is, I guess, hypothesis generating, was positive. This time they get a lot more dialysis per week, right? You're looking at 12 hours versus 30 hours. And you're looking at not that much more UF, but 1.6 liters a week. Same thing, the FOS definitely got better, but what we care about is the blood pressure, and that also you can see got better, fewer blood pressure medicine. Their weekly average dialysis, pre-dialysis blood pressure was lower. So 2 high quality RCTs, more dialysis, more fluid removal, better blood pressure, and probably reduces their cardiovascular risk down the road. But we don't actually do that often. So, but it is a proof of principle.
Do any units do the frequent nocturnal? That's just home.
Yeah, so what we do in some of our units, we do 4 times a week. And 4 times a week, the issue is Medicare only pays for 3 times a week dialysis. So if you do 4 times a week, you have to document there's something that some medical need the patient has for 4 times a week. So for me, it's almost always, clinical fluid overload, cardiovascular disease. And so if I do have somebody with high fluid gains, we can't get to their dry weight, or is always hypertensive, I will suggest they get 4 times a week dialysis. They will sometimes agree and sometimes not, obviously, because it's kind of burdensome. The other option, we do run a lot of people more than 4 hours. When I have anuric patients, I almost never run, I would generally never start at less than 4 hours if they don't make any urine. And I've had people who have dialyzed for 5 hours a week, just along the same kind of lines, that, the more UF you can get in a week, the better it is for their cardiovascular risk. But we, like you all, like with Isaac and Annie in the clinic here, they do next stage at home. So the actual treatment time is not that much higher. I'm not sure how much more fluid you can get off. It's definitely good for the patient's quality of life and their freedom and everything. But I think really to get these kind of benefits, you got to do something like nocturnal, where you really get that treatment time up quite a bit.
Doctor, how is this different from the findings in the hemo trial? They say that more dialysis is not necessarily better.
So the hemo trial, it mainly, so they did have a little more treatment time, but the hypothesis of the hemo trial, it was that 2x2 factorial design. So the first hypothesis is if you remove more urea, small molecules, they'll have a better outcome. That was negative. And the second part was if you use a high flux membrane, so you get more middle molecule clearance, that would be a benefit. And that was also negative. Now they did have a little more treatment time, but not nearly as much as this treatment time.
So it's more about the time than the clearance.
I think time, I think the pitfall to hemo, to be honest, is that everybody cares about KT over V urea, and you just care about how much urea you're moving. But if you just focus your treatment prescription on that, you might end up running, especially in women, because they just have smaller body size, you might be running very short treatments, and then you're putting them at risk for volume overload. So I think when you're writing your prescription, it's best to try to take a holistic view. Yes, I care about toxin removal, but I also care about, you know, ultrafiltration, blood pressure, et cetera, et cetera. And those variables will go into your treatment time. Okay, this is another randomized control trial. This is what most of us do in clinical practice now after this trial. This is called the DRIP trial. What they did was they took a outpatient hemodialysis unit and they randomized them to usual or not usual. And the usual care was like, if somebody shows up and they have edema or, you know, have crackle or rales and they are short of breath on exertion or then you drop their dry weight. And if not, you just kind of, if they're feeling good and they don't have edema, you just let them go. And the other group, it was, if they're still hypertensive, you drop their dry weight by 0.1 kilo pretty much every time. But then you do eventually get their weight down until they had some kind of like intolerance, like hypotension or severe cramping or something. And so just challenging the dry weight by that very small amount led to a very big increase in their in hypertensive control. So this is the intervention group with the squares. You can see after 4 weeks of that approach, the systolic blood pressure was significantly improved, 7.4 millimeters, and it was a durable effect. It's obviously only an 8-week trial. We don't know the long-term effects. And the one thing that always stresses me out about this approach is, well, first of all, it's hard to watch patients suffer with cramps, and I'm sure you all have seen people cramping on dialysis, and you know, if you do this approach, you're obviously going to increase the likelihood of cramping because they're not clinically fluid overloaded and you keep challenging their dry weight. But you know, that would, you know, easy for me to say, short-term pain for a long-term gain, right? Maybe you get their blood pressure under control and you decrease the cardiovascular risk. The other thing that worries me a little about it is in your patients who have just started dialysis, a lot of them have, you know, residual kidney function. And there, of course, is a risk if you're causing interdialytic hypotension, then maybe you're going to decrease their residual kidney function. Maybe they're going to be anuric in a month or two earlier than they would be. So, you know, you do have to weigh a lot of approaches. I would say in general, we do basically go with the approach on this trial where if all their post-dialysis blood pressures are high, they don't have pitting edema and they're hitting their dry weight, we generally will try to challenge their dry weight. Okay. So back to our patient. So she has those increasing blood pressures. She's concerned about them and wants to know if she should change her measurement. We talked about reaching her estimated dry weight and she has no intradialytic hypotension and cramping. And so based on what I've showed you before, you could say, well, she needs to do dietary sodium restriction. Maybe we should challenge the dry weight. I wanted to bring this slide in here because the other thing that I think you should, this doesn't apply to her necessarily, but what I try to do in my patients is leverage the EMR as much as you can. So this is a report, I assume DaVita does the same thing. I took off the patient names, but these are all individual patients. And I can print out a fluid report every month to see who's hitting their fluid dashboard. And this almost can tell you everything you need to know about the patient. So it's like how many of them have a high post-dialysis blood pressure. So like patient 1, 6 times, but they get a lot of interdialytic hypotension, so it's probably hard to challenge their dry weight. They always leave above their dry weight. That's what this post-weight variance means. It means that they're leaving more than a kilo above. So you can't get under their dry weight. They're always hypotensive. They don't miss or shorten. So some options for that patient actually might be you could extend the treatment time, maybe if you want to try to, maybe if you really do think that they need to have their dry weight challenged, you could do 4.5 hours. You could, maybe you could do dietary salt restriction because sometimes they do have a pretty high interdialytic weight gain. And then that's might be what you focus on. Now, this patient has a lot of hypotension or hypertension. They have no interdialytic hypotension, but they shorten their treatments quite a bit. So that patient might just need, you know, education on dialysis time. Maybe they have a transportation issue or something else you need to figure out. 3 missed treatments. This isn't a month, by the way, so 13 would be your max. This patient dialyzes for 4 hours, but shortens almost every single treatment. So the 4-hour treatment doesn't really do a lot. So I think the point of me bringing this up is you can usually print out these reports. You can also just get it on your rounding sheet. But when you're thinking about you have to be thinking about what the best strategy is for fluid removal. It might just be lengthening their dialysis time. It might just be, you know, really hitting hard their dietary salt intake and working with a dietitian. What happens if they still make residual kidney function? You can probably try to increase their diuretic dose to try to get that interdialytic weight gain down. So it's important to identify the underlying cause, and that's what I generally like to do with these reports when I'm rounding.
Patients that have like other post SVP. Well, I guess it's a different cutoff, so like the post SVP being greater than.
Yeah.
But they're pre-SVP.
Yeah. Yeah, and I generally ignore this except for one. There's like a phenotype, and it's more common in diabetic patients where they start out at like 210. And then you start UFing them. And I assume it's because they have autonomic dysfunction, but you start out at 210, and then like an hour later, they're 90/50 and they're having cramps, even though it's not a fast UF rate. And so that's the only time I really care about the pre-dialysis blood pressure is but yeah, like most of the time I just kind of ignore that. And that might not be the right thing to do, but yeah.
Do you ever use like UF profile?
Yeah.
Oh yeah, all the time. I do. So the patients I would use UF profiling on would be like patient 1, where you can't get them to their dry weight and because they're getting hypotensive. Or the other option would be cramping, right? Like maybe if they're cramping a lot. I always use UF profiling. The other thing Fresenius is doing now, which kind of makes sense, is that they are doing like UF only at the beginning of the treatment. So the logic being, you know, if you're not removing solutes, your blood's not getting hypotonic. So you're not going to get hypotensive from that reason. You'll only get hypotensive from a fast UF rate. So we generally think it's okay to go past that 13 mils per kg per hour if you're doing UF only at the beginning of the treatment. And so you obviously wouldn't do that if they're hyperkalemic or if they're have like low urea clearance. But a lot of people, 4-hour treatment, they get plenty of potassium and urea removed in 3 or 3.5 hours. So sometimes doing that extra UF, it helps as well. Okay, what classes of blood pressure measurement of blood pressure medications would you recommend? Well, I guess I'll just ask you all before I show you the 100% right answer. Jeff?
Me?
Yeah.
Thiazides, 100%.
Thiazides for Enteric.
100%.
Yes, patients. Okay, good. Anybody else? I guess when I said there was no wrong answer, I might have appreciated it.
Putting off with the wrong answer.
It depends, like.
Minoxidil.
Correct. is an option.
What'd you say? Minoxidil? Okay.
Glass blockers.
Grass blockade, yeah. Yeah, okay. Okay, cool.
Calcium channel blockers,
Calcium, like non-dihydropyridine, yeah, okay.
Suintresol.
but they will make you more hypotensive, I think. Terry?
Yeah. Oh, so yeah, this is actually one of those things, surprisingly, that has not really been that studied in high quality data. I'll show you the best studies out there. There's a meta-analysis where they did individual classes, but it's not great. This is the meta-analysis. There's actually, I think there's maybe 1 more or 2 more trials since 2009, believe it or not. But what I will tell you about a lot of these studies is that they were not designed on hypertension. Like this CCHE study from Italy it was LV dysfunction, so it was dialysis patients with LV dysfunction who they got randomized to carvedilol or not. So who knows if it was because carvedilol was having, beneficial effects. It was a positive trial. And then a lot of the other trials, I think Takahashi is for Cinepril. Can't remember what Suzuki is. I should have reviewed that before, but they all looked at an individual agent. And you can see some of them are kind of small. They have the big error bars. The CCHE kind of drives the results. And again, that wasn't purely a hypertensive trial. Neither of those CCHE trials. So they're more of heart failure and dialysis. So I don't think carvedilol is necessarily your first line agent, although it does have a lot of data behind it in dialysis patients. All right, so RAS blockade, because the question always comes up, what if they're anuric on dialysis? Do they still get hyperkalemia? And I can tell you anecdotally, before I pulled up these papers, I could tell you yes. Like I feel like I have started ACEs or ARBs in dialysis patients and then watch their potassium go up, in their pre-dialysis labs. And, the mechanism theoretically would be maybe there's some gut potassium excretion or something like that. I mean, honestly, who really knows? And the data is not great. This is, I should probably relook at this again, but this is a paper that looked at patients on dialysis with or without ACE inhibitor therapy or with or without, I can't remember, I think it was also ARBs, and whether or not they were anuric or not. And so if they got RAS blockade, they were more likely, that's their odds ratio, to get hyperkalemic. If they were anuric, they were more likely to get hyperkalemic. If they were anuric and got RAS blockade, they were more likely to be hyperkalemic. So I do think it happens. I do think it's something that should be monitored. I think in the Lokelma era, it is pretty unusual for us to have patients who have life-threatening hyperkalemia. I do use Lokelma often off-label in HD patients, just throwing it out there. I get nervous when I see pre-dialysis potassiums of 6.5 or greater. So there we do have some patients. And so I wouldn't use the risk of hyperkalemia as a reason not to use a RAS blocker. And then of course, 70% of dialysis patients have left ventricular hypertrophy. We know from the general population that RAS inhibitors work. So they seem, and they also have the vasodilatory properties, which are important in patients on dialysis. So they seem like good options, but yeah, you do have to watch for the hyperkalemia. Here's one of the head-to-head trials. I don't know how many of you ever talked to Dr. Linus about atenolol as an antihypertensive. He was adamantly opposed to using atenolol as an antihypertensive, and then I showed him this trial, and he still told me not to do it. But the theoretic benefit of atenolol, do you all know how atenolol is cleared and what the benefit is in dialysis patients?
It's an pathway clearance.
It's actually completely renally clear and it's completely removed by dialysis, which means you can give it 3 times a week. So you can dose it right after dialysis. It just hangs around until you show up for dialysis. Dialysis clears it and then you dose it again. So those are pretty nice pharmacokinetics, right? Because like from a compliance standpoint, yada, 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 it makes a lot of sense. So this trial randomized atenolol versus lisinopril. And I think they dose reduced lisinopril, but they still gave it daily. And atenolol actually won. So atenolol led to a better increase in the ambulatory blood pressure, both systolic and so Dr. Agarwal is at Indiana. I think he is still a big believer in using atenolol. And so if you look at some of the guidelines based on this trial, a lot of people do recommend that. I have anecdotally tried it. One issue is dialysis units don't stock atenolol. So they had to like bring their own pill bottle in and take it, which they often don't do. But we have noticed that I think it is effective. It's just, and Dr. Linus's point about atenolol is it's a pretty weak beta blocker. It has no vasodilatory properties either. So he did not think it was, like in the general population, you would never use atenolol as an antihypertensive. All right, what about the dialyzability? So most ACE inhibitors, they are renally cleared and they are dialyzed, it's generally recommended dose reduce. I have not really felt like I wanted to dose reduce because usually the blood pressure is not controlled. ARBs are pretty straightforward. You don't change anything about ARBs when you're on dialysis. Calcium channel blockers like amlodipine are CCB of choice, not removed, don't have to redose it. And beta blockers are completely, span the entire spectrum. It really depends on how lipid soluble they are. So like atenolol has a very low volume of distribution, so you can remove all the atenolol pretty quickly. Carvedilol is the exact opposite. So carvedilol is not removed by dialysis. Oh, I don't really need to go through all this. Where's the beta blocker? Oh yeah, sorry, here's the beta blocker one. So we don't use a lot of these beta blockers anymore, but you can see, so the drug label has recommendations on the GFR dose. Like for atenolol, they want you to use 25 to 50%. So in that study, it's either 25 or 50. They would never use 100 in a dialysis patient. And then even though this says 50%, I guess in practical terms, it's like it's getting removed. And so you should dose it again after dialysis. Some of the other ones you dose again. So I would say the most common ones we use would be carvedilol and labetalol, right? So carvedilol is recommended to dose reduce, labetalol not. Neither of them removed by hemo, and neither of them need a supplement, which is easy for us. It is a pretty big difference. This is the only study I've ever seen do this, where they basically measured the drug in the dialysate to look at the clearance. And so you can see here, atenolol and metoprolol are removed. They used bisoprolol, which I have not used in 15 years, which is kind of in between, and carvedilol, literally nothing comes out in carvedilol. So that, they do recommend dose reducing it, and presumably it's for this reason, that you might get higher levels and you're not removing any of it. Obviously we have all seen patients on like 50 milligrams of carvedilol and they don't, seem to be suffering any great toxicity. But if you look at the label, that's probably too high of a dose to be using for carvedilol.
Like if someone has AFib tocopherols, let's say, you just have them do it like after dialysis.
Yeah, you would definitely redose them after dialysis, yeah. All right. Okay, so it's not quite an hour, but it was gonna be hard for me to stretch this to an hour. But the ideal blood pressure for HD patients is unknown. It's reasonable to strive for a normal home blood pressure. Blood pressure in dialysis patients is very sensitive to fluid removal. The best pharmacologic agents for HD patients, sorry, there's my other typo, are unknown, but there better data for blood beta blocker and calcium channel blocker. So, I do think that is certainly a reasonable approach. Do you guys ever read, you all are ASN members, at least the fellows are, right? And like every morning there's like, how do I handle these difficult cases? This issue will come up, I would say once every 3 months. People are very dogmatic about this second point. There are some nephrologists who are on that forum and they will say that hypertension is non-existent if you have the patient at their dry weight. So people would come in and say, oh, but their post-dialysis blood pressure is in 170. And these very dogmatic nephrologists who probably do not see a lot of patients will say, oh, it's just because you're under dialyzed and you need to get them to their dry weight. And they shouldn't need any vasodilators. And they base that on the studies I showed, but also there's like a dialysis unit in France called the Ticine unit, where everyone gets like 10 hours of dialysis a day, and they show up, they have wine, a baguette, this kind of, and like nobody in that clinic has hypertension. And so the conclusion from their experience is that if you get enough fluid out people, they'll never have hypertension, which I just feel like is a big jump to extrapolate. But if you do see nephrologists say everybody on the only thing you need to do is challenge their dry weight, that's what they're basing it on, is like those observational studies from those kinds of clinics. So maybe one day I could do a sabbatical there.
That'll save the wine. Wow.
All right, any questions?
No.
Did you guys find that helpful? I hope when you're
Yeah.
rounding in the dialysis unit. But who's on Zoom? Kayla?
I don't know.
There's one other participant.
I don't mean, we didn't recognize the name.
Yeah, we didn't
Oh.
recognize.
Okay. All right. Well, I'll give you 10 minutes back, guys. Thanks for your attention.
Thank you.
Thank you.
I mean, the weird part is that
Oh,
UF totally fine. That was the weird part.
Yeah.
She UF like over a leader.
No, again, she's actually not clearing as well.
Temperature getting.
Yeah.
No.
Something's weird.
It was here.
Oh, never mind.
I don't know the end game.
All right, well, we're gonna talk
Okay.
about managing pregnant women that have CKD or end-stage PDD. Because it is becoming more common that you guys might see this. Okay, why won't it go away? Usually if I click on it.
Right?
Control
You
Shift
do.
Alt H.
Yeah.
If you just hover right under it. the
Right
green,
under it?
Like right under the green part bar, which.
I prefer dedicating 30% of my brain space to remembering.
And you see Shift Control,
What?
Shift Control Alt H.
Okay, there we go.
3% of our.
Okay, well, that's okay, you remembered that. Okay, so this is kind of what we're gonna talk about. Stop me if you guys have questions. There hasn't been a lot of new stuff in this area. I'll show you what there is. So we'll kind of talk about all these different things and like strategies and, actually counsel it to women, because you guys will have to counsel. So we don't really know the prevalence of pregnancies in women with CKD. It's estimated to affect about 3% of all pregnancies. But early stage, we don't really know, because a lot of these patients we don't see, nobody really checks it, their GFR, they might have some proteinuria. We end up seeing them in their subsequent pregnancy. Then they're like, oh, look, this person has, and I see these women all the time that now have this, and they all have CKD stage 1 to 2, because it's mainly just proteinuria. Advanced CKD, it's about 1 to 150 women of reproductive age, or about 1 in 750 pregnancies. And there's obviously reasons for this that we'll talk about. It's just much harder for these women to get pregnant. Not that they can't get pregnant, it's just harder to get pregnant. And in dialysis patients, this really hasn't changed much. If you look at the data, it's like we only have stuff when we look at like 10 years. And they tried to look again from like the more recent ones, but you just can't get this data. But it's still about 8.4 per 1,000 patient years. This is worldwide looking at this. In the US, the more recent data tells us, well, it's about 2.4% in women that are on hemodialysis and about 1.1% on peritoneal dialysis. So that's kind of the newest data that we have, but worldwide, we don't have anything really newer. So there's no doubt that we're getting more pregnancies in women that are on dialysis. It's more common in the younger ones, 25 to 29. More likely we get this with women that have GN compared to diabetes, again, for just other reasons why people sometimes with diabetes don't, can't get pregnant as easily as others. Conception is actually less likely if you're on peritoneal dialysis. And so this was data in the US, about 1,700 women on PD, and that's where they got this pregnancy rate of 1.1%. And then sort of from Australia, New Zealand, that's the ANS data overall, it's about 1.06 compared to 2.54 pregnancies per 1,000 person years. So again, women on HD seem to get pregnant easier than PD. And we don't really understand why this is. When you talk to the OBs, everyone's saying, well, maybe this hypertonic solution, right? Everything we put in their belly is going to be hypertonic. That it's in that space and it could interfere with when that ovum is actually transporting from the ovaries to the fallopian tube. And so that just doesn't happen as often. Again, these are just theories. We don't know, but when you think about our PD patients, they're usually healthier. Like when you think about who gets put on PD, at least at our institution, they're younger, they're healthier, but they still don't get pregnant. So,
I mean, just like logistically, you're on PD in the night. I don't know, right? I mean, I don't know. You can.
You can get pregnant with the day.
I was gonna say, I don't know. You can't get pregnant in the morning time. Or if there's something new with that, Jake. Let's figure. But you're right. I guess you might have to. So before we talk about abnormal stuff in pregnancy, let's just kind of go over what normally happens, at least for the things that we care about, like renal plasma flow, GFR. And as you guys all know this, renal plasma flow and GFR go up during pregnancy. So it is stressful on the body, right? This is a stress. The kidneys hyperfilter. Renal blood flow increases by about 70%. So kidneys do swell, GFR goes up by 50%. Proteinuria also goes up, right? Because if you're filtering more, these things happen. You get the tubular function. You get increased glycosuria, increased bicarbonaturia, plasma osmolality falls. And then we know renin
EPO and active vitamin D also go up. So these are all just normally what happens. But this is why it's a stress on, women's bodies when we talk about this, because this is like stuff that happens and what we expect to see. And so when we start looking at mean arterial pressure, and this becomes important for patients, right? Your mean arterial pressure should go down in that first trimester up until really you start, you're in the second trimester. After about 20 weeks, it does kind of rise back up. And by the time they're in the third trimester, it should be kind of back up to where they were at the very, when they were non-pregnant. Cardiac output goes up very early and stays up kind of throughout all of pregnancy. And plasma volume, it takes a little bit of time for these physiologic changes that we just talked about, GFR going up, all these other things. But plasma volume really starts to go up when you get around 20 weeks, and it stays there and basically until they become postpartum. After 40 weeks, ideally when they're delivering, and everything goes back to normal. So that's what we expect to see in people. So we know total urinary protein and albumin excretion do go up with your hyperfiltering. We don't see this a lot until after 20 weeks. It's primarily TAM horsefall protein, right? The ones we all have when you're seeing your little Highland cast, that's what you're seeing when people are volume depleted. So really we count abnormal total urine protein in pregnancy as more than 300 milligrams per 24 hours, right? Normal is 150 milligrams per 24 hours. The pregnancy, it's double that. GFR, it's going up by 50%, makes sense. Gold standard still a 24-hour urine if you're concerned. Obviously, really, you might see little increases in albuminuria, but any albuminuria is never normal, right? So remember that. Just like you see in other patients that you would see like, oh, even now we know even like 10 milligrams of albuminuria is not good. But in pregnancy, we don't really know anything about that beyond that. The problem with the definitions of CKD, it's interesting because Cockcroft-Gault overestimates. They did a comparison of Cockcroft-Gault to the MDRD. Nobody's done Cockcroft-Gault to the newer equations. But of course, when you compare MDRD to the newer equations, it probably, it still underestimates this. But nobody's kind of gone back to say, okay, let's look at Cockcroft-Gault versus all of these things in pregnancy. So 24-hour urine collections are really the gold standard, but we rarely need these. And they're just obviously cumbersome to do. But if you're going to do a 24-hour urine for proteinuria, you can easily at least get a creatinine clearance and kind of know where you're at. If the patient's already had stage 4 CKD for a long time, it's probably not as important to do this versus somebody who's maybe changing and has AKI. So what we see with CKD, and the biggest thing that happens is they can't adapt. So it's kind of like anything with CKD, right? The kidney just loses the ability to adapt when you have this. So you can't boost the renal hormones. So this is why there's more anemia in people with CKD who get pregnant. You don't have the expansion of the plasma volume that normally would happen. And then there's vitamin D deficiency. And the gestational rise in GFR is blunted. And so this is a bad sign. So those of you who've seen pregnant women with me, I'm like, oh, this is great. But their creatinine is like 0.5. I get very excited. If I see a pregnant woman whose creatinine is 1 or 0.9, I'm very worried because they did not have a blunting. If you knew that they started at 1.2 and they went to 0.9, that's very reassuring. And we do see this a lot. I'll see a lot of patients, even with not usually once they're stage 4, but even kind of getting close to stage 3B CKD, if their creatinine goes down, that is reassuring because you're saying, aha, they're still having a physiological response. We almost never see this if the creatinine is greater than 2. So that's kind of just a bad sign. Does that mean they can't get pregnant? No, but their kidney's not going to adapt is what it means. The more proteinuria they have, the less response and adaptation that you have as well. So here in the kind of gray, it's kind of hard to see on this screen, but this is less than a gram and this is more than a gram. And then this is just where their serum creatinine goes. So if you see it's before conception, if their GFR is over 40, that is huge difference. But we start to see that we're not seeing these changes in these people that have up to a gram. We're not anymore. See, it should be going down and it's actually creatinine staying up. So not only does it matter what your creatinine is, but how much proteinuria, which is why we want to try to get the proteinuria as low as possible when people are going into pregnancy. And this is why we don't stop ACEs and ARBs or SGLT2s until they're pregnant. Because you never know how long it'll take someone to get pregnant. They might get really lucky, they get pregnant in a month, it might take a year. And so you don't want them to get worse, whether you're treating a GN, whatever you're treating, prior to pregnancy. There is no doubt CKD results in adverse pregnancy outcomes. This is work we did a long time ago, just kind of looking to say, well, what was the risk? The biggest risk you have is preterm delivery. As you can see here, the 52% increased odds of having that. Extremely preterm was, it's luckily that doesn't happen very often. That's gonna be more happen in dialysis patients. Because there's more preterm deliveries, there's higher risk of cesarean sections. Makes sense, right? Length of stay in the hospitals also can be higher. Preeclampsia, any stage of kidney disease, even just having microalbuminuria is an increased risk for preeclampsia. And then on the fetus side, low birth weight, again, not surprising if they being born early with preterm, small for gestational age, admission to the NICU. And again, that kind of goes along with the preterm. But the good news is maternal death and infant death still remain relatively low, depending on when the gestational age is. And maternal death, we do pretty well, unless they get severe preeclampsia. Now, there's no doubt outcomes get worse as your CKD advances. We don't have a lot of data. This is like one of the biggest studies that we have. There's one more, but they didn't have really any stage 4. But it's sort of the same thing, like more cesarean sections, as we get more gestational week, you can see it becomes earlier and earlier when they're delivering, which makes sense. Unfortunately, birth weight, they get smaller, the need for the NICU. So it just kind of tells you can have a baby when you're not at advanced kidney disease, you have better outcomes. So this is kind of looking at progression of kidney disease. This obviously varies on where you start, what your kidney disease is from, and how well controlled it is. So most patients, this is looking at GFR during pregnancy. This was only, I think, about 67 patients that they had in this. But they look, they were stable from early in pregnancy to 6 weeks postpartum. It's like 57%. So most people do very well. And that's what you have to remember, especially when you're counseling people, right? You say, okay, they do pretty well. Now, you're going to have people who are going to have a reduction in their kidney function. It's about 23%. And then when we look postpartum, 31% of that 23%, it persists, meaning it does not get better. And then you have some people that have the antepartum reduction. And then of these people, the pregnancy-related decline with recovery is about 8%. And then you have some of these other ones that 6 months postpartum, you're still having a little bit of a decrease. So there's no doubt women can progress. And we've seen this, especially with specific diseases like lupus, for example. We see that the last one that we had she had 5 pregnancies, and she started dialysis with her 4th pregnancy at the very end. She progressed where she didn't quite need it at the end. We just delivered her, and then she was on dialysis during her entire 5th pregnancy. And so each pregnancy, kidney function just got worse. And so it happens, but it's kind of nice. You can at least tell them it's rare, and it kind of depends on where they start beforehand. So hemodialysis and pregnancy outcomes. So the big problem here is usually stillbirths and not having a live-born baby with people that are on hemo. Overall maternal and fetal outcomes are much poorer than the people that are CKD, not dialysis. So there's a lot more maternal deaths. And part of this is just because it is so hard to distinguish preeclampsia from just dialysis related things, right? Are they volume overloaded because of dialysis and we're not adequately doing it? Is their blood pressure going up because of dialysis stuff? Or is it this? You get a lot of prematurity and growth restriction in dialysis patients, especially because if they don't dialyze, as I'll show you, at least 36 hours a week. But if they conceive prior to dialysis, so let's say you have someone who's stage 4, and we've had this happen several times. They're stage 4, and you watch them, but then we end up having to start dialysis. They do a lot better. So if you actually get pregnant prior to being on dialysis, but then go on dialysis, you do better than if you get pregnant while on dialysis. And it's usually because we get lots of early pregnancy losses in dialysis patients. I've had a lot of dialysis patients get pregnant. It just hasn't gone to a live birth. They end up having a lot of miscarriages. PD, we have a lot less outcomes with this. It's really hard to know. As you can imagine, especially getting into the 3rd trimester, it gets very difficult to do PD. They can get more uncomfortable, drain volumes, so they may not drain, it hurts a lot more. Then acute peritonitis has resulted in adverse premature rupture of membranes and things. So again, having to be very careful. Exit site infections, catheter can be malpositioned, right? When you have a growing gravid belly with a bigger baby in there, things can change. And of course, peritonitis, but we just don't have a lot. Women receiving PD are more likely to deliver small for gestational infants than those on HD. Again, reasons we don't know. Is it just because they're restricted with now you have fluid from something else, other fluid? But there's no difference in the ones like preterm or live birth rates. So they're just smaller. So they get more growth restriction out of the ones that do make it. Residual renal function for sure improves pregnancy outcomes, just like it does for overall mortality and cardiovascular outcomes in dialysis patients. If you have residual function, you do better when you're having babies as well. Okay, so we'll start talking about how do we manage these people, right? Diagnosing pregnancy is really difficult. Can't tell you how many times I have my patients that are like, I'm pregnant. And I'm like, oh, that's yeah. And then we check and they're not. Because periods are very irregular. Oh yeah, did you have a question? I did. Oh, yeah, did you? No. Okay, I thought you raised your hand. I was like, okay. Advanced CKD, nausea, like things like this are there all the time. 30% of human chorionic gonadotropin, which is what the pregnancy tests measure, is cleared by the kidney. So we get a lot of false positives. And so that's, I have one dialysis patient who every month she's like, I'm pregnant. She has yet to be pregnant. But she always, and we always have to check, and but so you have to have some good collaboration between nephrology and high risk OB, which is what we do. So pre-pregnancy counseling, this is rarely part of the clinical workup, which is unfortunate. We should be counseling everybody, especially those you see in clinic, about your reproductive age, you could get pregnant. What do we talk about? And there's really not a lot of data on this. But what we do know from the data out there is like anything, women value reassurance, autonomy. They want some control, some emotional validation. When I was in training, it was basically like they can't get pregnant. We just don't talk about it. They don't get pregnant. And you're like, okay, well now I have a pregnant one sitting here. So what do they do? And we just didn't talk about it. And you just basically told them like, you can't get pregnant. It's not, you don't get pregnant. And that's not what people want to hear. And that's not what they're going to do, right? So we have to do better. And this was from work, it's been about 10 years ago now, from Alison Tong in Australia. And that's exactly what they find, that women were traumatized by their doctors because they were saying, nope, you can't have pregnancy. So they, in some cultures, if you don't have babies, that's, a big deal, right? And it may not be safe for them to have them, but you can explain it in a different way, or at least, give them that autonomy. Some of them, it's like bodily failure. So they're on to depression and things that we don't think about. Mental health get a lot worse because they're like, my body's fit. Why is this? There's guilt. There's all these things. And this burden that was there. And that's what they saw. Like we were traumatizing people. So, what do we do? So basically my approach is shared decision making, right? So you got to really communicate with them. What are their goals? And a lot of times they won't bring it up. We did a study here about maybe it's been about 3 years ago now, where we just surveyed everybody and we weren't bringing it up enough. We weren't asking. Most of the patients didn't feel comfortable asking their nephrologist about pregnancy or should I get pregnant? What should I do? But you want to try to do this. You can get them counseling. There's the OBs do a lot of the pre-pregnancy counseling. You can discuss the success rate. And I do that because especially when I have ones that are like, I really want to get pregnant. It used to be like, oh, wait till you get a transplant. Well, they may not have time to wait till they get the transplant. They're 37 years old and they may not get a transplant for 5 years. What are we going to do then? And so I do go over like the success rate. I try to find the window. So if we're talking with them, I'm like, well, your blood pressure is not where we really want it to be. You have too much protein, or, we can get all these things better. Your diabetes better controlled. The chances of the pregnancy being successful are going to be a lot better. And so we kind of look at that. Sometimes it's their window. I've had those ones that are stage 4, their GFR has been like 30, 29, just hanging out. I'm like, if you're going to do it, this is the time. Because if we wait till they're too far advanced, we'll be starting dialysis. So I go over risks, and this is what we do a lot, like in all my preconception counseling, like, yes, you probably will get preeclampsia. It's usually mild. Most women do very well. I think even my more severe ones make it to 36 weeks most of the time, if they're not on dialysis. Risks of medications, disease progression. So we kind of just talk about all these different things. And then for those on dialysis, I do tell them, or if they're advanced stage 4, what that looks like, because if we're talking about 36 hours dialysis a week, right? So that's every single day except for Sunday, pretty much. And that's a lot. And so we discussed transplant. Obviously, if they have a living donor and they could get transplanted in 6 months, and okay, let's go down that path. And then obviously birth control if they're not ready to start that. So this is what we do prior to pregnancy. Like, look, you know, you want to just document they're on an ACE or arvastatin. Okay, those things are going to obviously have to be stopped. SGLT2s. I don't stop any of that until they get a positive pregnancy test, ACE, ARBs, or SGLT2s. And then once they're pregnant again, or once like we start switching them to methyl-dopa, labetalol, or long-acting nifedipine. Methyl-dopa I don't use as much anymore. And then we still target, if they have known CKD, we still target blood pressures less than 140 overnight. And that's what the data tells us to do. You can use loop diuretics. You'll have to. If someone has stage 4 CKD who gets pregnant, you will absolutely have to have them on diuretics because they get very volume overload. We start, folic acid prenatal. And if they have advanced CKD or dialysis, they can usually take a regular renal multivitamin. Sometimes then they just add the folate on top of that. And if we kind of look at it and say, well, what is safer for them?
Doctor, I have a question about
Yeah.
the volume overload. I think I read once that they can have oligohydroamnios with loops. So how do you titrate the diuretic?
Well, I mean, you have to, yeah. So you basically have to just titrate it, right? If their blood pressure is going up, they're massively overloaded. And then you just have to watch the baby. So that's like you and OB and you're seeing them frequently. If they're needing escalation that much of furosemide, chances are they're going to be on dialysis in a couple weeks. And I've never seen someone not go into dialysis when we're ramping up and their edema is just worsening. And then their BUN either hits the magic number, because usually once you ramp up the furosemide, BUN hits 50 and you start dialysis.
I have a question about the pre-pregnancy
Yeah.
counseling, because
Yeah.
we occasionally have like CKD3B patients who are like, yeah, I want to have another kid. Well, yes, want to be with you with that, but how do you characterize their risk of progression? Because they're like, what are the chances that I am gonna?
Well, it varies on what's their underlying kidney, right? So if it's lupus, it's a lot different because the lupus isn't well controlled, quiet for a good 6 months to 9 months. Their risk is much, much higher.
Okay.
And then it's kind of like with any GN, like if they just got off all this immunosuppression, and you're like, okay, are they stable? Are we thinking about additional rituximab dosing? And a lot of times we just do that. Like we just had one with Joanne Zell, because with Rheum, and she was like, well, no, this has all been stable, but I just feel like I should just give her some Ritux before she does, and she's been very stable and we were all like, let's do it. Let's just give her enough. It's not going to hurt her at this point. So those ones are a little bit more difficult. The chance of progression is pretty small if everything's well controlled. If you're pregnant and your GFR is 20, the chance of progression is very, very high.
Okay.
If you're stage 3A, very, very small. Are they going to lose some GFR? Absolutely. As I showed you, like 20% are probably going to lose some. But it's not enough to need dialysis. Are they going to switch stages from 3A to 4? No. And more than likely.
Well, it's like a bad preeclampsia or something.
Right. You never know, right? If they get preeclampsia and horrible AKI, all bets are off. But it's really, you have to kind of look, I will tell my patients whose A1C is 10 and has a lot of proteinuria, this is not going to go well. Like you should not get pregnant. And then when they do, unfortunately, the two I've had do that have lost the babies. Because usually the body, and that's what the OBs say, like they kind of makes the decision for them. If they are on GNs and they're on, mycophenolate or things, you have to be a little bit more aggressive with your counseling of them, because you have to be like, you can't get pregnant on this. So if we're really thinking about this, I want you at this point would be the best time. We got to switch you to AZA. You start doing all that. Then we want to see you stable on AZA for 6 months. And so it's hard to answer that without knowing the patients. But there's stuff you can find. Like if you look at, and I can send you guys some stuff like where you can look and say, okay, here's the actual risk. It's not high. But if you're starting with, 5 grams of proteinuria, it's much higher than someone who has 4.
Gotcha.
Does that make, just like any CKD?
No, it makes sense.
We just don't have a prediction equation, which would be wonderful.
Yeah, it would be. I'm just thinking.
You can still use their KFRE and be like, here's your risk anyways, your kidney failure risk equation. They have a lot of proteinuria.
I'm thinking about like those patients with like 1.4 GFR 35, maybe a secondary, like that kind of
Those
thing.
kind of- yeah.
The patients we see more frequently,
Yeah,
like where.
I mean,
it's
if they have over a gram.
Yeah.
And if they're not maxed out on everything, I've maxed them out on SGLT2s, ACE, everything before or while they're trying. So that way, when they go into the pregnancy, maybe they're at 500 milligrams.
Gotcha, okay.
And then you know it's gonna rise during, because you have to stop those meds, it's gonna go up. But then they usually do just fine. We see a lot of those at GFRs of like 35, 40. something like that.
So if they were like, if their KFRE for the next 2 years was already
Terrible.
pretty high, you would be like, the pregnancy probably has a high
Higher
chance
risk, yes,
of you.
because I mean, it's a stress on the
progressing.
body, we have to stop these medications.
Yeah.
Right, and you have to weigh that too, because like we are stopping your ACE, that's probably, and your SGLT2 that have been keeping, right? They can't be on GLP-1s during pregnancy. So all these meds that we put them on to reduce that risk, and now we're like, hey, you actually look good, their proteinuria is the best it's been, your creatinine stable at, 1.5, and this is great, or, and then you just don't know. Most of the time, though, like I said, most of the ones I see, they do just fine. The ones who get severe preeclampsia are the ones we worry about the most.
Yeah.
Because then they get bad AKI and then they come out of it with worse kidney function than they went in. But
You might come to this later, but if you have someone that's like, say you have them on all the things and their proteinuria is not so bad, but you're gonna stop them, then like, how do you then reassess their proteinuria off all the meds? Like, do you just see them?
you just follow it. Yeah.
And
I mean,
it's-
like if you know it's diabetic nephropathy,
Yeah.
or, I mean, that's the most common, right? I mean, we see the GNs too. Or they've had IgA and their proteinuria is nothing. On the SGLT2, your ARB, once they're pregnant and you stop it, it's going to go up.
Right.
And then you just watch it.
And
But
then
it goes
you'll
up
see
before
it
20
be,
weeks.
yeah, you'll see it be relatively
Yeah.
stable, and then it'll go up as their pregnancy progresses.
As everything gets, and it might go up pretty fast, and then
Yeah.
you watch it, and then the harder part is after 20 weeks, when you're doing,
Trying to decide if
preeclampsia is gonna
it's-
occur before 20 weeks. I've seen it probably confirmed probably twice. But they do very, very bad, and babies like not, most of the time women don't even have, till 20 weeks ultrasound to like look at how baby's growing. So when we see those people, they're in the hospital with severe hypertension. They have proteinuria and baby's like not growing. And that's when they're like, this is probably severe preeclampsia before 20 weeks. And these people, it's a lot harder because like, was their protein going up just because
Right.
of their disease?
Yeah.
And preeclampsia.
How do they diagnose preeclampsia on people?
I mean, you do it because you watch their blood pressures. And when you have to add more and more medicines, it's preeclampsia. Not just gestational hypertension, especially if they were well controlled before. And it gets very hard. And you try to make it to 35 weeks if you can, but we'll have to deliver sometimes at 34. Okay. So this is the usual stuff, kind of get everything comprehensive, all these things before you're getting pregnant. All right. So now what happens once they are, right? Because you guys do this stuff all the time. Pre-pregnancy. All right, so when you have one of these patients, you have to really monitor it jointly by nephrologist and the OB. If there is high risk OB or maternal fetal medicine, you want to send them there at least once to get those people on board. Their OBs will do that, but in some more rural areas, like we see a lot of the patients from the rural areas because MFM here does telemedicine. And so then they'll bring them to us. Like we don't physically see them, but I'll give recommendations to maternal fetal medicine for those people. Usually monthly visits, they're doing this anyway at their OB. So I usually see them at least once in the first trimester. Sometimes I don't see them till the second trimester. If everything's going well, I just have them get labs. They just let me know. If they're obviously advanced CKD, I don't do this. But if they're like stage 1, 2, early stage 3A, I'm like, hey, just get labs. Let me know what blood pressure or things are happening. If they're more advanced, obviously I see them more frequently. And then I usually check labs every 4 weeks. And then after, when we're getting into the third trimester, or if we're starting to worry about preeclampsia, sometimes it's every 2 weeks. It just kind of depends what you end up needing to do. I'd have to get labs every week to start looking for changes. So nothing is really different with what we do if they get pregnant. You still target the same hemoglobins. We don't really do the ESAs unless, they're really advanced CKD, need it, because there's still the black box warnings. Like I said, blood pressure, leave it less than 140. You don't actually need to restrict phosphorus or any of this stuff, usually because the GFR, if they get a little bit of that, you don't want to restrict them. Again, now we're talking about the way advanced. Early ones, you're not going to have to worry about this. You just let them eat. If you need binders, use calcium carbonate because some of the other binders reduce absorption of fat soluble vitamins and folic acid. So calcium carbonate doesn't, that's just Tums, easy to take. But you do liberalize diet. Daily protein intake can be a little bit higher. And obviously we treat any vitamin D insufficiency or deficiency, but that OB is usually very good about that because they're treating that more from the fetal side. And then we try to maintain serum bicarbonate. Again, this is just all like people out there, oh, try to get in the normal range. So it's 24, but if it's like 22, 20, I don't really mind that too much. And try to avoid hypocalcemia and hypophosphatemia if you can. So preeclampsia, though, the risk is high. So any of my patients who get pregnant, they all start low dose aspirin at 12 weeks. If they started earlier than 12 weeks, it's not going to make any difference. And so some of them will do that. And so but you absolutely have to start aspirin at 12 weeks in all of these patients. So if you remember anything at the end of the first trimester, everybody gets on aspirin because that does reduce preeclampsia risk. Starting dialysis in these people, right? If we're not going to be starting dialysis if they have CKD 1, 2, early stage 3. These are going to be your CKD 4s. Your GFRs are under 30 when they get pregnant. So if you start having bad volume overload, like we talked about, electrolyte imbalances, you can't control their potassium, like, right? Like Lokelma, I don't know, I'm not supposed to use it in pregnancy, can we use it? I don't know. So you wouldn't, right? So this is a problem. Refractory metabolic acidosis. Now, this is where outcomes are better when the BUN is less than 50. So kind of the hard stop for most people is the BUN. So if the BUN gets to greater than 50, some people even use greater than 40, they just start dialysis. Or if the GFR declines to less than 20, usually your BUN is going to get to 50 because you're adding furosemide, you're adding other things that make the BUN go up.
Would that be a reason to switch to HD in a PD patient because you get tighter control, or usually?
No, usually you can, yeah, you just have to really intensify PD.
Okay.
Yeah, I'll show you that in just a little bit when we get to the HD ones. But that's kind of it. Like otherwise you just manage them like you do anybody during pregnancy. You're just following and watching for preeclampsia a little bit more frequently. But otherwise, this is the only thing you have to look for, which is why we get labs very frequently. Because if that BUN hits that number or the electrolytes are becoming problems, we start them on dialysis. Postpartum, again, I resume ACE inhibitors if I can before they leave the hospital. If I'm very, very worried, if they have significant proteinuria, if you can use captopril, enalapril, or quinapril. I usually use enalapril since it's once daily, makes life easier for them. ARBs haven't been adequately studied, so I just switch everybody to enalapril that are breastfeeding. And then you can just kind of monitor your creatinine levels. And hopefully by 6 weeks, if they have preeclampsia, that was, preeclampsia on top of their CKD, that proteinuria will go away and you'll kind of be back to where your baseline was about 6 weeks postpartum. Okay. Let's talk about on HD. So this is why adequate dialysis is so important. So this is kind of where we get this cutoff of 49 or 50, because babies that are born over 1,500 grams and obviously above 32 weeks do much, much better. Okay. And so you can see this, that when that's kind of the magic number here is BUN of 50 on both sides. And so that's kind of where we target that. So if you have a dialysis patient, the goal is to keep their BUN less than 50. CKD patients to keep it less than 50. So these uremic toxins don't cause all this bad stuff to happen. There is a significant dose-response relationship between dialysis intensity and live birth rate. And so this is what most of our dialysis patients get, right? 0 to 20 hours a week. Most of them are 4 hours, 3 days a week. So 12 hours, right? So live birth rate less than 50% for those women on dialysis who get that. Our standard of care, even up to 20, that'd be 8 hours over our current standard of care. It's about 75% when you get up to 36. And when you're above 36, it's about 85%. Now in Canada and other countries, they do this, above 30, they do like 37 or higher. We're lucky if we can get the 36 in our country, but it's a big increase in live birth rate when we do that. Again, higher significant pregnancy survival. So this is again the 0 to 20 hours. You can see they don't do as well. Here's the 21 to 36, and then the top line is greater than that 36 hours per week. So this is what we do. We do 6 hours, 6 days a week. If they were not on dialysis prior, if they have residual function and they were stage 4 and they go on, I don't, and go right to 6 hours, 6 days a week. But we definitely do it daily, but we might be like, oh, we still have enough residual. We don't have, and we kind of take all that into account. But when you do daily dialysis, it's obviously much easier to manage fluids, right? Because they may gain a little bit, they're not gaining as much, we're not pulling as much, so they don't get as hypotensive. There's less need for antihypertensive medications when we do this, which is also nice. And that also helps you diagnose preeclampsia, because if you took off blood pressure meds because you were and all of a sudden now you're adding them back and blood pressure's going up, then you're like, uh-oh, this is probably preeclampsia. Less polyhydramnios if you have better volume management, and that's for sure. And so goal is to keep the pre-dialysis BUN less than 50. It's not hard to do when you're dialyzing them every day. Everyone's BUN is really low, and usually it's less than 35. And that's some of the other recommendations. You let the women gain weight, so we don't usually remove fluid unless they're volume overloaded physically on exam that you can see it. So we let them go up by 1 to 1.5 kilos in the first trimester. Not a lot, right? These women don't need to gain a ton. And then they go up by 0.45 to 1 kilo per week in the last trimester. So we want them to have that for the baby's growth. And then again, aspirin at 12 weeks. So a lot of these people will start aspirin even sooner, but you can do that.
Do you start the 36 hours in the first trimester?
Oh yeah, right away. Yeah, the minute if you have your current dialysis patient and they're like, guess what, I'm pregnant, and you confirm it, yeah, you start it.
Do they come into the unit and there's in a chair?
So they'll come to the unit until the baby's viable.
Okay.
And so you have to check what viability is with your NICU. So most of the time, so this is where it's been hard for people who are very rural and they don't have a NICU and a place to do dialysis. So they'll sometimes stay in their unit longer than they would. So here, viability is 22 weeks where they will resuscitate the baby. So when I say viability, it's when will your NICU resuscitate the baby? It used to be 24 weeks. Then they do it down to 22 weeks where they would actually, so at that point, so until 22 weeks or whatever it may be, 23, you dialyze them at your unit 6 days a week. They have to accommodate it. You accommodate it at, another chair at another unit, whatever has it that you can get there 6 days a weekend. Once they're viable, we admit them. They come in Monday and then they dialyze in the hospital and they stay there Monday to Saturday. They go home Saturday night, they get Sunday off and they come back Monday. And we dialyze them hooked up to monitors. So you do it in L&D, right? So they're admitted to the L&D floor. We bring the dialysis thing there, and then that way they monitor the baby. If anything happens, they go right to a C-section. The last one we had on dialysis, she was my patient. We made it to, started dialyzing her 22 weeks in the hospital. She made it to almost 26. She was 25 and 6. And then baby did not do, but turns out she also had like groupie stress, so it's probably not really just the dialysis, but baby was in a lot of distress during her dialysis. But this is what's hard this is why you have to also counsel the women, like this is what it takes. And I know Seth had one that they tried to dialyze her 6 days a week and she didn't show up. And so that happens. And not much you can do. Once they're in the hospital, the last one we had who did well was the one with lupus on her 5th pregnancy. And so she'd come in, some of the kids would come spend the night with her there for a few times. But she would just do that every week until she delivered. And she made it, I don't want to say we got her to probably 37 weeks. So she did really, really, yeah, she did really well. So everything you target is the same for anemia. But remember, they're going to need higher doses of ESAs, these women on dialysis. So we end up giving them a lot more ESAs. They need more IV iron sometimes. Blood pressure, again, we try to avoid intradialytic hypotension. This is why we do it every day. And you're not trying to pull a lot of fluid. You actually may have to, because we dialyze them so frequently, you usually have to give them FOS. So or you would tell them like, hey, you need to. Most of the time the women enjoy it if they're already on dialysis. They're like, hey, I get to go eat a bunch of these high FOS foods every day that I never could. PTH goals follow KDIGO, but we don't use cinecalcets. You actually have to just use activated vitamin D. which is actually helpful in these situations because phos is usually low, calcium's usually lower because we're dialyzing so frequently. So we do volume assessments. Monthly, you can kind of do that in the first and second trimester. But then we're basically doing it weekly or daily. The OBs usually would do it daily. And when they were here in the hospital as fellows, you guys would go see them daily and you could assess like, oh, do we actually need to remove fluid? But usually it's just set to minimum. Whatever they prime the machine with 500, ours here use 500, you take off that 500 and that's it. That's all you're doing. So they're coming out net even so they can gain weight. You liberalize their diet, you liberalize kind of all that stuff. Treat vitamin D. So those things are all the same. Again, if they have a lot of residual renal function, you can tailor it, but that's not going to be your people that have already been on dialysis on chemo. They lose residual function very quickly within the first year of dialysis. We use unfractionated heparin to prevent clotting, so you can definitely do that. And then again, once fetus is viable, you do fetal monitoring the whole time. Dialysate potassium, you know, usually when we're doing this, I start at 3 if they've had higher ones, but usually you have to be on a 4 dialysate bath at some, you know, if you're doing daily. And bicarb, you usually need to go lower because again, you're giving them so much dialysis that usually it's like 25 to 30, not your standard like 35 that you're doing. And then fetal monitoring, this is more like where you're high risk, they'll be seeing maternal fetal medicine and high risk they'll be the whole time, but they'll do these Doppler assessments, they'll do sort of all these other things. So I just kind of leave that up to them. They're just like, dialyze them. I'm like, okay. So that's kind of what we do. So preeclampsia. This is the hardest diagnosis to me in women with dialysis. Most of the time, we can diagnose this pretty easily if they're CKD not on dialysis, because again, you know your patient. They've been able to control their blood pressure with, let's say, just nifedipine and low dose labetalol the whole time. And now all of a sudden they're 33 weeks and their blood pressure is just going up. And they call you, and these women, you have to have a monitor at home. And they'll call me and say, oh, and we'll say, okay, double labetalol. Or they went and saw their OB because they're on weekly visits and like, oh, we doubled the labetalol. Okay, labs are okay, you know, so we kind of just watch them. But then when they're like, oh, we're doubling labetalol again, or that didn't do anything, that didn't touch it, usually that's preeclampsia. A lot of times we'll admit them, see if we can get them closer to 34 weeks. If it's before that, if it's any time, like we just usually deliver everybody at 37 weeks. So if you have bad CKD, or anything, if you get to 37 weeks, we are super happy and we do not let them go beyond that. So that's usually a recommendation to 37 weeks delivery. But that's the hard part. So I'll show you some S-split1 stuff that we still can't get it in real time. So that's the hardest part with that. But the hard part is like, if we misdiagnose it, then these women get delivered when baby maybe doesn't do as well. And this is the hardest part where women don't want to deliver the baby because they'll tell you like, you know, the chance of your baby living is very small. They're like, nope, I'm just going to risk it. And then if it's preeclampsia, they usually get sick enough where we say you have to, and they'll end up doing it, but it's really hard. Keep muting active. Okay. I don't know what that's about. But again, you have to kind of do all these different things. Obviously, if they have help or things that are developing, it's automatic, but.
So when you like admit them, it's just like daily labs, constant blood pressure monitoring.
Yeah,
And
and that's all you
anything
can really
with,
do.
like, fetal stress.
Yeah.
Or
Because they're going to be in the
platelets
hospital. The
dropping.
dialysis patients will be in the hospital.
yeah.
So you'll see them. And if the, you know, if the woman's like, gosh, I'm having like, we had one, lots of chest pain. That was just weird during dialysis that she'd never had the whole time. And then all of a sudden started experiencing chest pain. And then we'd stop dialysis, see if it goes away. So that's why you have them there. And then baby was under stress, but baby did okay. So we were able to just kind of watch her. We'll see where she's at the next day. But you just kind of stop dialysis early. It's more your CKD patients that aren't on dialysis because they're not getting that daily. Even when you're in the hospital dialyzing, someone's seeing you every day. They'll see the differences. Blood pressure is being monitored the whole time. So it's going to be more of those from clinic. And that's what I usually just tell them. You got to check your blood pressure. If you get headaches, your swelling is worsening, you got to go in. I don't even tell them to call. I'm like, headaches, swelling, you go in. And then sometimes we are able to admit them, watch them, and it's not that bad. So we're like, okay, they'll be okay. And usually I don't make that decision. That's OB's decision. They'll let them go home. We just admit them and keep them until they get a little closer to term or enough time to give steroids or whatever you need to do to infant lung development or something if we can. But if things get worse, then they're at least admitted. But if you're escalating blood pressure meds, And, they call their OB and they're not as worried, you need to call them and say, no, I'm very worried.
Yeah.
And do that. So S-split1 to the placental growth factor ratio, you can diagnose preeclampsia with this. This is some of the newest stuff that's been out there. And you get this like risk score from the ratio test. You can look at this at 20 weeks. Like, is it going to predict who's going to go on? And they actually said, yeah, if it's over 85, these women are really high risk for preeclampsia. Oh, these are going to be most of our patients, right? So it's like hard for us to use this. This is why the OBs are like, this is useless. Because all your patients are always high risk. I'm like, I know. But you can follow the ratio. Ideally, if we had this in real time, right? You could follow the ratio after their 20 weeks. Say, hey, this is where you're starting. Oop, now it's this much later, a month later. Oh, you're way higher. Or this. And then all of a sudden, if they're developing more protein in the urine, their blood pressure is going up, that you're like, oh, is this preeclampsia? Is this just kidney stuff? And if the ratio has gone way higher than it was, then you can kind of be more likely to that. So this like rate of change, it can provide stuff in pregnancies. So we can get it, but right now you have to send it to Cedars-Sinai to get it. And they'll run it for you for free, but it doesn't help you if you have that patient in front of you right there in clinic that you think has preeclampsia. So it's going to be more of those that you're like, things are mild, I'm kind of escalate, like, gosh, I've gone up a little bit on the beta wall, volume's a little worse. What do I do? You could send it and kind of get a baseline to see where you're at. And if it's really high, then you might be like, but again, you really have to look at the patient. If they're only at 28 weeks, are you really going to deliver them based on this? And the OBs are like, no, they'll deliver them based on this. But it is going to become more commercially available, so it might help us in the future. Again, like I said, the treatment for preeclampsia is delivery. So you have to deliver them when they get there. Obviously, you have to be a little bit cautious with mag sulfate if they're on dialysis. You still can get right because you don't get toxic with mag until the levels are very, very high. So their level gets to 5 grams, and I get a little worried. Yes, we're going to dialyze them, so it'll be okay. So you give it. So I never withhold it if they're like really worried about eclampsia. But you can just reduce the bolus and then do things by half the dose. Just remember half. Like if they're asking you and everyone's worried, just give them half the dose. But don't say, no, we'll just give like very small doses of mag. Because they give very large doses of magnesium. Again, women can breastfeed as desired. You just have to be really careful that you don't over UF them. So that I don't think I've ever had one that's been able to breastfeed that have been on dialysis just because it's so hard with the fluctuations in fluids and they just don't make enough breast milk. They have to supplement. You could restart again the ACE inhibitors if they were on them. Some people may not have been. And then it's kind of the same stuff with like the heparin. So does that make sense? Kind of what we do. I mean, it's a lot, but if you guys want to know, it's once you do it. If anytime we have somebody, you guys end up seeing them. We just haven't had anybody that's gotten on dialysis has been pregnant in the last. I think the last one it's been 3 years now.
Last year I think there was one.
There was one last year,
And
but
I think Annie's patient, they were dialyzing 6 days a week. Yeah.
and she was because that one we started, but I think that was the last one we've had.
I also have a patient delivered at 30 weeks last week.
Okay.
It's a Rennie's patient as well. She came, but her creatinine was actually better. You baseline at 1.3, and when she was here, she was like 0.8. And she was admitted because of preeclampsia, concern for preeclampsia. They kept her here for like a week, and then she didn't want more monitoring, so she decided, I want to deliver. They did a C-section on her.
Yeah. Well, I mean, probably things were not getting better.
Yeah.
What happens, and you have to weigh the risks, right? I mean, preeclampsia is the number one cause of maternal death, and that's the one thing we don't. If it's already been diagnosed and things aren't stable, or some labs you have to deliver. I was gonna say that last one, and I saw her on her second pregnancy, she did a lot better. We met her during her first pregnancy, and she delivered at 28 at 5 with severe preeclampsia, didn't have prenatal care. She has FSGS. I diagnosed her that during her second one. She got pregnant on her arm.
Oh,
But it's okay. She knew to stop it. She wasn't supposed to be getting pregnant. But then she came, but we still biopsied her because it was early enough and it was FSGS. And then she had a bunch of proteinuria. And then unfortunately it's APOL1, so there's nothing to do. But she did fine in the second pregnancy. And then I said, please no more babies for a while.
Yeah.
She's like really young. And I was like, let's give your kidneys a break. But yeah, it's very hard. And we see more and more of them. But she wasn't on dialysis, that was just.
No, she was not on dialysis. She was on lisinopril, and she didn't stop because she didn't know she was pregnant until 19 weeks.
Yeah. Yeah, I mean, it's usually late second, third that you're more worried about lisinopril, but. Yeah, I mean, this is why you have to really count. If you don't trust the person to stop it and be on top of it, you have to stop them ahead of time.
Yeah.
But then the pregnancy time should go as well, unfortunately. Yeah, I had one that had lupus and got pregnant on things they weren't supposed to get pregnant on and babies. But then didn't want to, even though they recommended termination because baby had serious growth. It was very sad. And those are just the cases you don't, it's never fun when we get called or we have to manage them because it's usually, they want us to come in and confirm to the woman, you have severe preeclampsia, you have to deliver. And it's really hard when they're like 22 weeks because you know it's not going to go well. But, and you'll see that more and more. I mean, you guys will, but I've seen it many, many times, unfortunately. Okay, so PD. The nice part about PD, they're already doing it every day. So it doesn't change their lifestyle as much. But you have to do a little bit more gentle ultrafiltration. They have less anemia on PD. They don't require as much ESAs, which is nice. And you have to really liberalize their diet though, because you are going to increase it. Of course, like we talked about, really in the third trimester, it's hard to get them as much PD as they need it because they get uncomfortable. Again, data is based on case series. I think Isaac's had like 2 or 3 over his entire career. So, as he'll tell you, he's old now. It's a long career, right? So there's not very many. But also, I would say back in the day, they would just switch him to hemo. So he might have had more, but we didn't know as much. Continuous therapy is what you do during the third trimester. So no dry day at all during APD or dry night if they're doing CAPD. So you reduce the 12 volumes, but you increase the number of cycles, which makes sense, right? You can't, if they were getting 2 liters then and now there's like, you probably have to reduce it and you have to do it more frequently. We don't know the target clearance. So this is what's really hard is you're like, I don't know, no data. So 2.2 to 6. Really it's like the more the better. That's the way I look at it, right? So up to 22 liters per day, if they look at the one with the best outcomes, that's what it's been.
Great.
That's a lot, right? So you think about that especially if you couldn't do 2-liter exchanges, like you're just exchanging, It's a lot. Again, trying to keep the BUN less than 50, but it may actually need to be lower in PD, we just don't know. So there's just not as much data. So yeah, kind of leave you with, I don't know, with PD. Ask Isaac, right? But everything else is the same, PTH, everything else you do the same that we did for PD. Now it's interesting with them, they don't necessarily, they're not getting admitted to the hospital. So this is something too that you just talk about with OB, because right, they don't need to come in to do this as with hemo to do the crash C-sections. But if things are not going well and they're getting more volume overloaded, they can't tolerate it, then that's a little bit different. But you're not bringing them in to dialyze. Okay. So the last few weeks of gestation we do, but not like from 20, not from viability like you do with hemo. But you can obviously, when you really need to get lots of in there, very, very rapid, hopefully, because they've made it to 35, 36 weeks, you can get there. And then peritonitis, you basically treat it as you would anybody that's not pregnant. You want to treat it right away if it happens. Everything's similar to HD, delivery at 37 weeks, breastfeeding as desired. And we should encourage it, right? We want to. But if they don't want to, they can't. I always say fed baby's the best baby, right? It doesn't matter. You feed that baby. So these are the prescribed drugs that are considered as relatively safe for CKD. So ESAs, they don't cross the placenta, so they're considered safe. Cholecalciferol, that's our nutritional vitamin D. It crosses the placenta, but the transfer is very low. So there's no adverse effects. And that's why, it's very standard where they treat vitamin D deficiency with that. There have been adverse effects with ergocalciferol, so it's class C. So really, we just give them the daily cholecalciferol if you need to do it. Right? And OB is usually on top of that. We don't usually have to decide that. Calcitriol is teratogenic in animal studies. There's no adequate studies in humans. So you have to just really look to see, does the benefits outweigh the risk? Like, is it really going to be bad for them to have 9 months of a PTH of 800? Or is it going to be worse if I give them calcitriol? So I usually be like, you can probably be 800. And again, when you're getting daily dialysis, FOS is way better controlled. PTH usually comes down. So it's not usually a problem, but You don't use cinecalcets. If you had to use something, you would use activated vitamin D. Sodium bicarbonate, no animal or human data is available, but they do just fine. I mean, think about people, pregnant women take Tums all the time, they're taking carbonate. One just has a little more sodium in it than the other one has calcium, so it's okay. Calcium carbonate, again, it's really not a sign, but pregnant women are supposed to take Tums for GERD, so if you think about it, it's safe. So it's okay there. So for the antihypertensive drugs, labetalol and nifedipine we use all the time, and they're both class C compared to methyl-dopa, which is class B. But alpha-methyl-dopa has more side effects because it's not centrally acting. But you can use it, especially if you need a third agent and they, are limited by things. Nifedipine, just like any other calcium channel blocker, can give more edema, so you just have to look out for that. Second line therapy, those are your first lines that you always want to go to. Then we don't like to use beta blockers besides labetalol because the beta-1 selectives can cause fetal growth restriction, so we really try to avoid those. Clonidine, similar to methyl-dopa, but it's just not as safe. There's more rebound and other things we don't like to use. And again, diuretics, hydrochlorothiazide is a B, but most of the time we don't like to use that for some of the sulfa and the other things that are there. The loop diuretics are a C, but hydrochlorothiazide is not going to control anybody that has volume overload, as you guys know, so you can use in the loop diuretics. Now, you can't use spironolactone. I don't have this in here, but more and more now, we are using a eplerenone, and it's safe. So if you have someone, and Annie had one not too long ago, we all had to discuss it and review everything, but we used a eplerenone in her, and she did very, very well, and baby did fine. So if they're on Spiro, and that's what they need for blood pressure control, you can switch them to eplerenone. So yeah, so that's kind of what I have for you. So again, don't automatically discourage pregnancy. Really use that shared decision making, because then, I think you open up that communication, they'll trust you more. Like if you're like, I think you should wait 6 more months before you start trying, or we have this. If you have this communication where you're not just telling them no, and it's going to be really, but you give them all the information. And again, should just be part of our routine care. Intensive dialysis, low dose aspirin. Again, if you don't remember anything, you can always call me when you see me in practice. My ex-fellows call me all the time around about 9. When they see these people and they'll be like, "Oh, my dialysis, oh my God, what do I do?" Start 6 hours, we do it and we help manage them. But remember the aspirin, because that's the best thing you can do right away, and make sure you stop their ACEs and the bad drugs, and then you're okay. There's breathing time, like anything in nephrology, right? You know how they're super emergency, dialysis or not. Okay, now we have that. We have time to figure it out. And then, there's not Annie can tell you, we get them from all over. Where their nephrologists don't feel comfortable managing them during pregnancy, so they come see us during pregnancy, we manage them, then they go back. So we've been seeing a lot more PKD ones, but then they want to stay here as per peak. But I'm like, okay, now that you're off that, I don't do Tolvap then, because you have to do Tolvap when they're pregnant, right? So you're like, go see those guys who do that stuff. And then I see Michelle, Ruth, or Charles that do that part. But we're seeing a lot more of those. But there's no doubt. I mean, I have a new one. I am seeing an Alport's one tomorrow, who has Alport's, and then I saw one last week who has proteinuria and mild. She's going to be fine. And I have another one that I'm following now that we have no idea what happened, because she had delivered her first 2 babies in another country. Severe preeclampsia with the first. Then she has no idea if she had preeclampsia in the beginning with the second. Made it longer with the second, but got severe preeclampsia again. So I'm very worried she's going to get severe preeclampsia for the 3rd time. But blood pressure and everything's controlled, and her proteinuria is about as best as it can be, and she's already pregnant. So I'm just gonna knock on wood and follow. But yeah, so we're getting more and more of these. It's just hard. Like Judy and I with our women's specific clinics that'll start in August. Hopefully most of them will be funneled there. So won't help from the second year that are finishing, but for the first years, there might be more opportunity to see them. Because right now it's just like when we have them in clinic and we don't know when. But if you guys ever want to join our MFM that we have, it's with us and Room and maternal fetal medicine, and we do it. I mean, unless we have a bunch more, it's like every other month, and we meet and we kind of go over all the pregnant patients we're managing. Also, we do the preconception stuff, right? Because that's what we just did last week when we had it. When Dr. Zell had one that wants to get pregnant, and she was worried, but I was like, I'm not too worried. Like everything looked stable, and so we just came to consensus of rituximab and see what happens. Cause like, it's always hard when you're just on AZA. I'm like, is that gonna be enough during pregnancy with some of these? But they do great. So I think she'll be fine. Yeah, so if you guys want to, let us know. We can send you the invite. We do it on Zoom because we're all in different places, so. And Denver Health, if you guys have patients you want to talk about, you can join.
Yes.
Yeah. I actually have a good amount of pregnant.
I think 2 or 3.
Pregnant
At
patients
least.
that I see.
Yeah.
And I love it when they bring their babies before
Yeah.
that's active. Like,
Yeah.
When they bring the babies the next
Yeah.
time. you're like,
Usually hear them, they sound fresh.
Yeah, I know.
Yeah, and really, but once you see them, if they have preeclampsia, see them back at 6 weeks, right? So if you're really worried and then they've had bad proteinuria prior, because it's your patient you've been following, start the enalapril before they leave the hospital. And then see them at 6 weeks. At 6 weeks, if it was just preeclampsia, like most of the time, we don't even see them in the hospital, right? We don't see the preeclamptics that don't have known kidney disease. But if their proteinuria persists at 6 weeks, they'll send them to you. And then at 6 weeks, that's when you say, sometimes you can give them a little bit longer, but I don't usually give them more than 3 months. So if after 3 months, if it was severe preeclampsia, but they still have a lot of proteinuria, I biopsy. And sometimes you're just going to see scar because they had a lot of AKI and there's nothing else there. But those are the ones that you worry there's with an underlying GN and there's something more you can do. And this is the good, again, window potentially. And that's when you have those conversations of, now we got to give you immunosuppression. You got to stop breastfeeding.
Yeah.
But
I've had several that are like, don't have any care between
Yep.
pregnancies.
you have no idea.
And so you're like, they get sent for proteinuria
Yep.
early in pregnancy and you're like, that's close to what it was at the end of your last pregnancy, so I guess it's fine, we'll just watch it.
Yeah, and most of those people do great, right?
Yeah.
And then when they come back, you biopsy them. So I've had several like that. I have one that I biopsied her. She's got thin basement membrane.
Mhm.
Did genetic testing, it's negative. Her proteinuria has been unchanged on max dose ARB and SGLT2. I mean, it's only 250 milligrams, but it's completely unchanged. So I'm like, probably some Alport that I just don't know. My other one is truly Alport's her mom and brother have it. And her proteinuria, she got severe preeclampsia in her first pregnancy that I didn't see her with. But then she's had this low, about a gram, it just doesn't change. But she did fine. Like they do fine in their, they get preeclampsia. I don't think I've ever had one not.
Yeah.
And it's mild. Most of the time it's been very mild, but then they make it to 36 or 37 weeks and you're like, this is a win. Those ones usually do very, very well. If their proteinuria is worsening, steroids. So Judy can talk more about that with the GNs. She's got a lecture on like GNs and that, but we'll do that all the time. Steroids aren't going to hurt mom. They're not going to hurt baby. And if your proteinuria is just going, then you definitely start steroids. I start anticoagulation when it's over 4.5 grams.
Steroids with a known GN or steroids?
Without it, I mean, if
Just
you're
pure-
pretty sure, like, you're like,
You're
they
like,
had
yeah.
proteinuria at the very beginning, right? Like they first OB visit at 10 weeks
Yeah,
and they have proteinuria and it's worsening and now they're nephrotic range and it's just worsening. And they're nephrotic range and they're at like 16, 17 weeks and you're like, wow, this is not, you anticoagulate them, you might try steroids. Because it's gonna be, to see if it's, again, if their age group, like what would steroids do? Well, it'll calm down and it'll change. Like for most pregnant women, right? So you have to kind of look at that. It's very rare we have to give steroids, but you can. Most of the time you're giving anticoagulation. And so usually my threshold's 4.5 grams. If they're over 4 on a spot, then I make them do a 24-hour urine, kind of see, and then they just
Can
get
they
started.
do
Lovenox.
What?
Yeah, you just give them Lovenox. Yep, they do Lovenox, and then the only thing that's why you got to work closely with MFN because then they stop it. Like obviously, if it's scheduled induction, we know and they can stop it ahead of time. It's just we put it in their plan. Like we write these notes that are like their plan to be like, okay, try to stop it before the planned induction at 37 weeks or C-section. But they need to know that so if they come in like need a crash C-section, it is what it is. They try to hold it and then you continue it after. And the OBs are usually, again, okay, we're going to continue it for 6 weeks after, maybe just 5. It kind of depends on the person. Proteinuria, but that's the most devastating thing you just don't want to happen. So they just do Lovenox shots at home.
What's the gestational age that you would be like, I'm not biopsying after that?
If they can't lie flat on their stomach, I don't biopsy. I've done one with them sitting up with Isaac when I was a fellow, and I told him never again. But that one was like, again, we didn't know bad AKI. She was probably, how many? She was 24 and something, so not quite 25 weeks, but enough where it was uncomfortable for her. And everything went fine. But there's just, Isaac might still do it, I don't know. But I have yet to see him do another one since then. So, but yeah, and most of the time you don't need to biopsy them. You just tell them something's brewing, something's there. And that's how I counsel all those people that come with proteinuria. You're higher risk for preeclampsia and a preterm delivery, need for a C-section. And I always tell them though, most everybody, they do well. But I haven't had those women not do well. So I tell them like, it'll be okay, but you're going to have to just follow and do what you need to do. And they do okay. Then afterwards, you might find what they have and then go from there. It could be scar from their first preeclampsia.
I guess that's true, because.
It was the most common cause of nephrotic range proteinuria in a pregnant person. Preeclampsia. Always preeclampsia. That's your favorite question. Always.
And it's like nothing, there's not many treatments, like even if it was some other thing, other than steroids. like
Right,
you
there's
said,
really
there's
nothing
not-
you can give them
Yeah.
safely. Like you want to avoid cyclophosphamide. I mean, if you can't and everything is just. But that would be a big conversation, whether you're doing rituximab.
Yeah,
Would it even do anything if you're treating? It's more of what you're treating. Luckily, in this age group, we don't see that very often. Like sometimes, they have bad lupus. And then their lupus flares, which can happen during pregnancy. And then we have to like really adjust, but usually it's steroids. They manage them,
It's
unfortunately.
just steroids, right? But then at the same time, it's still, the pregnancy is very
Correct.
likely not to go well.
Right, if they flare.
Yeah.
Exactly. That's why like for lupus, that's probably just the one we have the most data on, right? Because it's more common in women and they get, so it's more data that if they're not well controlled, really quiet disease for at least 6 months, they do not do well. But I mean, as well, they still, most of the time, they still do well, don't get me wrong, but they're the ones who are more likely to advance if they don't, right? Because they weren't well controlled before. And that you'll know that with diabetes too. Like we see a lot of these type 1 diabetics now from Barbara Davis that want to get pregnant. A lot of the type 2s, if their A1C is well controlled, things go well. If they're not, they definitely say, you really shouldn't get pregnant now. This is not a perfect time. That's what I say. This is not the good window. We should have a better window in another few months when your A1C is better, or a baby has a much better. Because usually when I put it in the mindset, a baby will do a lot better.
I had a recent surprise pregnancy.
Oh yeah.
A1C of 10. But luckily all is well so far, and A1C is down to like 6
Good.
or whatever it's supposed to be.
Good.
I think the
Every day,
20
20 weeks.
ultrasound was okay.
Okay, good. The last one I had was so devastating, and her A1C was probably 11 or something. I was seeing her for her first visit to me, and she had just come from her 20-week ultrasound, and baby had anencephaly.
Oh.
And she came up and she's like, I don't know what I know. So then we ended up just like having, it wasn't anything about her bad diabetic kidney disease. It was more, but then she got everything together, very young, type 1 diabetic, things weren't, and then she had 2 great healthy pregnancies after that. And both babies were great. I mean, she got preeclampsia with both, but not till 37 weeks, but she did great. And has 2, now I don't even see her anymore because they're like, she has no proteinuria, her pump's great, her creatinine's normal. So I'm like, hopefully I don't see her again in 20 years. Yeah. But yeah, but yeah, if you guys ever have questions, feel free to reach out. Because there's not very many of us that do this. It's like Annie and I and Judy will do some of the GNs when we get the really crazy GNs. We'll come Judy. But like Sarah Young with lupus, she hates doing it. So Joanne Zell tells her, she's like, nope, Sarah does, so she'll call me or Judy and Annie every time. It's just a comfort level. And the other ones are like, never want to do it. They're like, go ahead. Go see that.
I'll just put them in that
Yeah,
word
yeah.
out there, be like, here's a great angle.
Yeah,
no, I
and again, we don't see them all the time. Like we see them once, and if everything's going well, they can go back, especially if they live far. And the last one I had, she lived in Fort Collins. And I was like, she saw me once, then we just did telehealth, and then she'd come see MFM, and we kind of, but we get a lot. Then I'm like, you can go back to your other, and they do. Usually they're like, okay, but I think it's more what the nephrologist feels comfortable. But I mean, there's no
Like,
reason.
even if you're in the line of